celebrating you and your achievements. I am Drishi Punjwani, and I am honored to be your host for the evening.
Welcome to Global Health Asia Pacific's 9th Summit.
In all our earlier speakers this morning, there's 3 themes that cut across most of the topic. The first one is on patient-centric. If you listen to speakers, they speak a lot about patient-centric.
We are here today, which is honoring yourselves. So I'll say that we've done a lot of thought sharing, knowledge sharing today. So let's enjoy the evening and do a lot more glass cheersing.
I'd extend a warm welcome to everyone here today. We are looking forward to having a wonderful day with a wide range of speakers and panels.
night is about you, and we're here to celebrate you and your achievements over the last 2018 going into 2019.
Good morning, ladies and gentlemen. We're going to start in about 3 to 4 minutes. Thank you for your patience.
Welcome to the 2021 Global Health Asia Pacific Healthcare and Medical Tourism Awards. Congratulations to all the winners of tonight. We look forward to seeing you and many more next year. Thank you for being a part of the 2021 Global Health Asia Pacific Healthcare and Medical Tourism Awards.
Ladies and gentlemen, distinguished guests, esteemed speakers, fellow colleagues from the healthcare industry, and all the professionals within healthcare from the region. Good morning, Selamat Pagi, Om Swastiastu. My name is Ravi Shrestha, and it's an honor to welcome all of you to the second day of the Global Health Indonesia Summit 2025. We had a very insightful first day where we discussed a lot of innovation. We exchanged ideas, interacted with people, and we are starting to shape the future of healthcare in Indonesia and beyond. So before I begin, I'd like to extend a warm welcome again to all of us here, as well as people that are joined virtually, right? So let's give ourselves a round of applause, please, as we start this day. So first and foremost, in respect, please could you stand up now for the national anthem of Indonesia, Indonesia Raya. Thank you. So to officially officiate and open today's session, I have the honor to invite Mr. Varun Panjwani, who is the Chief Executive Officer of Global Health Asia Pacific, up on stage to give the opening remarks. Varun, please.
Thank you. Hi, good morning, everybody. It is an honor and a pleasure to be amongst all of you, distinguished guests, partners, friends. Whilst this is Global Health Asia Pacific's first inaugural Indonesia Summit, this is our 10th year organizing and setting the standard for medical tourism, facilitation, and partnerships. With regards to partnerships, over the 10 years of us doing these events and summits, what has stood out is the friendships and the partnerships that we've created, but also the ones that have been created amongst yourselves. And what we're looking forward to is seeing the same happen within the Indonesian landscape, within these summits that will grow year to year. And we're very confident on that, given the changes, the innovation, the traction that Indonesia is showing. And whilst a lot of you here today vie for different positionings in the market, how to stand out, competing with each other for different medical tourist channels, what is admirable and inspirational is how when it comes to the quality of care and when it comes to the patient, all of the competition is put aside and the same partnerships and friendships come to be. And that is what is truly amazing and inspiring to see how everyone comes together and collaborates to put the patient first and move the quality of care forward. In the spirit of collaboration, I want to start today's summit and day 2 by thanking 3 collaborations that we are having. First and foremost is, of course, JMM. I would like to thank them for being our more than just Indonesia partners and really drivers for putting together this summit. So thank you, JMM. The second The second collaboration, and again, a partnership that we're going to see grow year on year, is what's bringing together the growth and elements of innovation into Indonesia. And for that, I would like to thank the NUS team for bringing together an entire new segment to this summit. So thank you, NUS. And last but not least, as there will be many thanks, and I would be here up all day if I did go through them, but I would be amiss not to thank the collaboration between the Ritz-Carlton and, of course, our own Global Health team for working tirelessly around the hours to put this together. So thank you to all of you for doing that. On that note, I will step off the stage, hand it back, and let the collaborations, friendships begin by letting everyone share their knowledge and exchange notes. So on that note, have an excellent day too, and thank you everyone for being here.
Thank you, Varun, for setting the tone for collaboration and all our teamwork that we hope to aspire today for the rest of the day. Next, I would like to invite Mr. Yudianto, who is the President, Director, and founder of JMM Consulting. He's, of course, a very respected figure within healthcare in Indonesia, as we know, and we're honored to have him to actually mark this occasion with a welcoming speech.
Thank you. Good morning, selamat pagi, Assalamualaikum warahmatullahi wabarakatuh. Namo Buddhaya, salam sejahtera, Om Swastiastu. Again, please welcome into the first Global Health Indonesia collaboration with the Global Health Asia Pacific. So, like what I said yesterday, this agenda is basically to start the collaboration. We get the direction from the MOH Republic Indonesia. It is a private hospital, private company, and especially now we have in here the CEOs of the government's hospital too. So this is really a good sharing and then learns each other and then include the transfer of knowledge among us for the Indonesia healthcare company. And then we heard lots too since yesterday is distinguished guests from Asia Pacific and include China guests as a speaker. So with this today's agenda from the Global Health Asia Pacific and Indonesia, we will start how to collaborate together, networking among all of us in here, and then we'll start with the others agenda all years in 2025, and then we have to be ready for 2026. So I believe all in here it is have a good agenda, better agenda for the future healthcare, even though healthcare in Indonesia especially. Allow us to introduce our distinguished and honored guests from Ministry of Health Republik Indonesia. Please welcome Dr. Sunarto Mkes, the Director of Ministry of Health. Thank you, Dr. Sunarto, for your support in the middle of your hectic schedule with the Minister. Thank you very much, we really appreciate. And please welcome Pas Setiaji, STMSE, a Senior Advisor to the Minister for the Health Technology, Ministry of Health Indonesia. He already became the master for 5 years, last, for develop and starting the best digital healthcare for Indonesia. He is the one that, the thinker, and then who developed the Satu Sehat. So it's already, how many, Pak? 40,000? Yeah, healthcare industry in Indonesia already joined the Satu Sehat digital. So now the ministry already have the data for the healthcare for the Indonesia citizen. And then this year it is continue again for the free screening medical checkup run our clinics or puskesmas around Indonesia. Yeah, that's why our minister really busy to go around Indonesia for this free screening for Indonesia citizen. And I will continue. Please welcome to Dr. Iwan Dakota, SPJP, Mars, as a President Director of Cardiac Hospital Harapan Kita. It's the biggest government hospital, especially for the cardiac. We'll develop another 20 floors building again this year. Hope will be finished. Yeah, so that's why we need to learn each other for the cardiac industry. It's success already, doing the many surgery in East Indonesia until Papua as the lead for the teaching hospital for cardiac among 250 hospitals in Indonesia. So just get the awards from Dr. Sunarto, from the ministry. I think 6 awards for the best. I'm not remember, Dr. Iwan, what kind of the best. I read this is a 6, yeah. Include the best EBITDA. I remember because I'm finance, yeah, so I remember EBITDA. Yeah, so the best as a teaching hospital, the best for the services and everything. So we will learn from you, Dr. Sunarto. And second, Dr. Okti Palupi, MPH, MHAKES. She is the President Director of the Women Children Hospital for Harapan Kita. This is another Harapan Kita, the biggest of women and children in Indonesia, government hospital. I don't know how many hundreds beds that you will build, yeah. Yeah. Maybe 300, 200 beds. Yeah, it will be huge, yeah, because they have a good children care in that hospital, and then include the fertility center. Yesterday we heard from the Alpha, maybe we can collaboration, yeah, Alpha IVF with the RSAB Harapan Kita. So that's why we put everyone in here. This is all the C-level, CEO, President Director, the best one in the Asia Pacific, so we can collaborate each other. Then we continue to Bapak Eric Daryl Tenda from the RSCM. Oh, maybe not arrived yet. Okay, from the Rumah Sakit Cipto Mangunkusumo. We introduce to Dr. Hadi Prakoso, SPM, from the eye specialist. Welcome, Dr. Hadi. Dr. Hadi has a new eye specialist clinic. It's exclusive in the big tower building in the Sudirman, yeah, doctor, yeah. So it is really nice eye center with the latest technology. Yeah, please welcome Dr. Hadi. And then continue with Bapak Yusuf Halimi, I think not arrived yet, yeah. Okay, Bapak Yusuf Halimi is President Director of EMC, Elang Medica Corpora Hospital Group, yeah. It is one of the biggest group too in Indonesia. Dr. Radi Muharis, SPOT, Orthopedic from MMC Hospital. Maybe not arrived, yeah. This is another big hospital at South Jakarta too. And please welcome Ibu Merlin Wijaya as the Sales Manager Intersystem. Not arrived yet, okay. And please welcome Dr. Yanwar Hadianto Mars, President Director of Pondok Indah Hospital Group. A bit story about Pondok Indah, Rumah Sakit Pondok Indah is actually our benchmark for the private hospital since long time ago. They have a really good services, not only for the patient care, include the digital one, and then include the specialistic, and then include the center of excellence. In the South Jakarta, we are the one who stay in the South Jakarta. We love to go there, especially for our kids. It's really good, and especially not only good in the treatment, but it is good too for the infrastructure, because they really concerned into the infrastructure and include the food. It's very nice, the canteen there. Yeah, My wife is really love, yeah, compare than waiting the kids in the pharmacy. She just left into the canteen. Yeah, and I'm waiting in the pharmacy. So thank you very much, and all of you in here that are already as a speaker yesterday, very good, and then we learned a lot from you all. And again, please welcome, and then we can continue the agenda. Thank you very much.
Terima kasih Pak Gidi. That was inspirational. It brings the bridges that we bring together in terms of Indonesian healthcare. And that's a nice segue to the next speaker that we have. So the next session is about raising healthcare standards within Indonesia, which is continually rising. We have the esteemed honor and pleasure, as Pak Gidi said, to have Dr. Sunarto here. Dr. Sunarto is the Director of Referral Healthcare Service Governance at the Ministry of Health within the Republic of Indonesia, and he will discuss raising healthcare standards in Indonesia to elevate Indonesia's competitiveness within the Asia-Pacific landscape. Dr. Sunarto, please, the stage is yours.
Oke, thank you. Selamat pagi, Assalamualaikum warahmatullahi wabarakatuh. Om Swastiastu, Namo Buddhaya, Salam Kebajikan, and good morning all of you. I want to make maybe little sharing about hospital transformation in health system transformation. Maybe I would like to present in Bahasa in English because it's so many policy in my presentation. Okay, slide. Oh, sorry, slide, just slide. Okay, it's a transformation house of health system. Jadi ini adalah rumah transformasi kita, Bapak Ibu. It's not just for Ministry of Health, but it for all of us. Jadi ini memang kita jalani sampai 2024 ya. Kemudian di 2025 kita mulai berkembang lagi, tapi ini tetap menjadi dasar dari transformasi kita. Kita melihat ada 6 transformasi di sini ya, 6 pillar. So where the hospital transformation position in health system transformation slide. Yes. Transformasi rumah sakit itu mengambil 3 pilar utama, Bapak Ibu. Have 3 pillars. Is a referral transformation system. The second is human resources, and the second is a health transformation. Maybe I down in here. It's so hard for me to see the screen. Okay. Jadi memang transformasi rumah sakit itu sekarang itu mengambil 3 pilar utama dari 6 pilar. Yes, it's the second pillar, is the fifth pillar, is the sixth pillar. It's a health referral service transformation. It's a main pillar hospital transformation. So we can see what have done in hospital. Apa yang harus sudah dan akan dilakukan oleh rumah sakit terhadap transformasi ini. Bapak Ibu semua kita akan mengerti bahwa the function of hospital to have a 3 function: services, education, and research. Jadi itu semua yang harus kita lakukan di dalam transformasi ini. Jadi kita tidak bisa berpikir hanya services, tapi kita harus berpikir tentang education atau teaching and research. Dan itu adalah transformasi dari rumah sakit itu. Jadi Kementerian Kesehatan akan mendorong rumah sakit memiliki pendidikan yang baik. Rumah sakit memiliki penelitian yang baik. Ya. Apakah itu government hospital, private hospital, all of hospital should have health services, a good health services, good teaching, and a good research. We hope that. Jadi 3 inilah semua ini yang harus kita kerjakan. Mengapa Bapak Ibu? Karena saat ini kita merasa bahwa human resources kita, terutama dalam dokter spesialis, tenaga kesehatan, kita merasa kurang semua. Sumbernya semua diambil dari mungkin pendidikan yang tidak banyak. Oleh karena itu kita mendorong rumah sakit itu, hospital itu bisa become a teaching hospital. Ya, mendidik dokter-dokter kita, memproduce spesialis gitu. Jadi hospital base, university base is okay, apapun itu. Jadi itu kita mendorong di pilar yang kelima. Di pilar keenam, bahwa nanti Pak Setiaji mungkin digital transformation. Kita mendorong bahwa rumah sakit tidak cukup lagi seperti sekarang. He should have technology in health system. Jadi use telemedicine, kemudian teknologi-teknologi kesehatan yang lain, stem cell, genomic, everything. Jadi apa kedepannya yang kita ingin harapkan Ministry of Health? Kami mengharapkan semua ini bisa berjalan di rumah sakit. Ya, even itu adalah private hospital. Jadi tidak cukup hanya memberikan health services, tapi kita harus education and research. Makanya kita mempunyai satu kebijakan tentang clinical research unit ya yang sudah berkembang sejauh ini. Slide berikutnya. Nah, so what the changes in hospital management after Law 17 2023? Apa perubahan setelah Undang-Undang 17 di rumah sakit itu? Kita tahu Undang-Undang 17 sudah dikeluarkan, didorong lagi dengan PP 28 Pak Yudi ya. Apa sih yang berubah? Pertama jelas, classification hospital akan change. Jadi change-nya di klasifikasi hospital. Nanti kita ke depannya tidak mengenal lagi rumah sakit umum, rumah sakit khusus ya. Ya, kita hanya mengenal mungkin kelas A, kelas B, kelas C, kelas D, tapi just that. Kemudian apalagi berubah? Competency based referral system. Jadi maybe before Law of 17 itu referral system itu based tier. Jadi berdasarkan jenjang-jenjang ya, harus D, C, B, and A gitu ya. But now referral system based on competence. Ya, kompetensi dari siapa? Kompetensi dari vaskes, kompetensi dari rumah sakit. What is the competence? It's a combine between human resources and medical equipment. Itulah yang membentuk kompetensi itu. Ya, and kompetensinya itu per layanan. Jadi bukan per rumah sakit. Itu yang membuat nanti kalau teman-teman rumah sakit yang dibayar oleh Jaminan Kesehatan Nasional itu akan berlakulah disebut single tarif. Ya, single tarif. Makanya dengar Chris yang sudah mau jalan nanti saya sampaikan juga. Dan yang terakhir, changes in hospital governance. Jadi hospital sekarang tidak bisa lagi palu gada, apa palu gada itu ya. Lu mau gua ada, itu tidak bisa lagi. Jadi hospital tuh harus punya center of excellence ya. If we say RSAB, we just remind, oh, it's a mother and child, gitu ya. Jadi harus ada center of excellence-nya dan semua harus kolaborasi. Tidak bisa satu rumah sakit mengerjakan semua hal, nggak mungkin. Jadi kita harus berkolaborasi, memang benar. Jadi saya sangat senang Mbak Yudi. Jadi kolaborasi between government hospital and private hospital is so important to make our health services better. Jadi itu penting sekali. Jadi 3 hal ini yang banyak berubah setelah Undang-Undang 17. Kalau dulu kita hanya mengandalkan sizing, besar. Ya, type A, BPJS akan bayar mahal. Ya, type B, BPJS akan bayar lebih mahal dari type C gitu ya. Tapi nanti itu tidak berlaku. Slide. Nah, is the hospital qualification before Law of 17. Jadi yang sebelah kiri itu kelas A, kelas B, kelas C, kelas D itu masih tetap ada, still have a regulation of type A, type B, type C. But it's not just a referral system, itu just registration and lisensi. Lisensinya tetap tipe A dari Kementerian Kesehatan, tipe B dari ini. Minimal tempat tidur 50. Ini tipe A, tipe B kayak kita. Orangnya besar, kecil, kurus gitu ya. Tapi orang besar, the big person, itu bukan berarti dia lebih smarter than the little one, gitu loh. Bukan berarti seperti itu. Jadi bukan berarti type A is more expensive dari type B, itu nggak ada lagi nanti. dilihat perlayanannya. Ya. Kemudian specialty hospital nanti tetap ada grading ini. Tetapi itu hanya untuk perizinan, untuk registrasi. So, we go to forward to competency hospital, competence hospital. Yes, combined between human resources and medical equipment. Slide. Okay, like this. It's a left side is a regulation of MOH is number 1 in 2012. It will so we have revision is with number 16 2024. Jadi dulu itu ya udah rujukannya seperti ini yang berjenjang. Nanti akan bergerak ke kompetensi. Makanya Bapak Ibu semua di rumah sakit manapun, saya kira mulai sekarang berpikir aku itu unggulannya apa gitu. Tidak perlu mencapai unggulan, tidak perlu begini. Nanti layanan itu akan kita bagi-bagi menjadi paripurna, madya, utama dan sebagainya ya. Jadi kita mungkin mengambil sikap, oh aku kalau jantung dekat-dekat dengan Pak Iwan Jakarta, aku cukup utama aja deh gitu loh. Gak usah bersaing dengan Pak Iwan. Biarkan saja Pak Iwan mengerjakan yang sophisticated. Ya kan Pak Iwan? Heart transplant, biar aja jantung harapan kita cukup open heart surgery, ya, bypass gitu loh. Tapi kalau vision mission rumah sakitnya mau mengerjakan itu is okay. Cuman sekarang pikirannya seperti itu. Lanjut. Lagi. Nah ini adalah sistem kita yang bergerak. Saya kira udah persis ya bahwa rujukan itu bisa kemana-mana saja. Termasuk rujuk balik. Tetapi memang minta tolong Pak Haji nih. Karena rujukan kita itu nanti based online Pak Haji. Ya based online. Ya tidak paper lagi. Kecuali memang daerah-daerah timur yang seperti itu. Karena nanti kita mengharapkan di PMK 16 itu muncul kompetensi-kompetensi dari rumah sakit. Tidak ada lagi yang namanya pasien rujuk ke sini nggak bisa, ke sana nggak bisa dan seterusnya seperti itu. Ya, jadi kita sudah ada di Sistem Informasi Kesehatan Nasional. Ya, sekarang kita lagi proses RPMK-nya Pak Haji ya. Lanjut. Nah, ini adalah define ya, paripurna what is that, utama, madya, dasar itu apa. Jadi itu sangat tergantung dari spesialisnya berapa dan ininya berapa. Lanjut. Nah, so because our change our referral system in a based on competency, now we go to single tarif. Untuk is special for JKN, BPJS. Jadi itu jadinya make sense ya, karena kita sekarang berbasis kompetensi sehingga nanti berlaku juga. Ini saya cerita BPJS Bapak Ibu, bahwa itu akan berlaku single tarif. Saya nggak mengatakan single iuran, itu belum tahu tuh. Kalau iuran BPJS kita nggak tahu itu apakah itu juga belum, saat ini belum bergerak ke situ. Tetapi yang jelas bahwa rumah sakit besar kecil ya to do same thing ya, mengerjakan hal yang sama akan dibayar sama gitu. Jadi kalau dia rumah sakitnya itu type A, do seksio gitu ya, so another hospital type C seksio is the same price. Jadi oleh karena itu saya sering mengatakan ke rumah sakit pemerintah vertikal yang rata-ratanya itu sudah terlanjur besar, kerjakanlah memang kompetensi yang harusnya dikerjakan oleh rumah sakit besar. Ya, kerjakan tuh. Kalau enggak nanti akan report ke saya, Pak Noto kami rugi, klaimnya enggak cukup gitu loh. Karena mungkin ilustrasinya seperti ini Bapak Ibu. Bapak Ibu punya Mercy, punya BMW, tapi just around Jakarta and Bogor. Jadi kita enggak tahu tuh keunggulan mobilnya apa. Kalau mau tahu keunggulan Mercy and BMW, you go to Semarang. 440 km by tol. Nah, baru kelihatan keunggulan rumah sakit itu. Sonala, lu harus ambil dari luar negeri pasiennya. Oke, jadi seperti itu Bapak Ibu, single tarif. Ini kita cerita, kita talking about BPJS ya. Di luar itu nggak ada aturan yang mengkontrol itu. Maksudnya nggak ada aturan mesti seperti itu. Ini kita cerita adalah BPJS. Ya sekarang kita akan merubah lagi proses Inasi Bijis menjadi Inadi RG. Lanjut. Jadi, nah ini saya sekilas saja, mungkin kalau Pondok Indah tidak ada BPJS ya, nggak apa-apa juga Pak. Tapi ini memang BPJS akan drive ke situ, karena Indonesia punya rumah sakit sekarang sekitar 3,223 maybe hospital in Indonesia, and 80 or 90% is collaborate with BPJS. Jadi itu hampir sekian persen rumah sakit itu bekerja sama dengan BPJS. Jadi 12 kriteria kris ini akan mulai diberlakukan di 30 Juni 2025 this year. Ya, June 30 June, the end of June, we will publish this regulation. Jadi kita harus mengatur bahwa kris itu berlaku untuk BPJS. Jadi BPJS itu menjadi satu kelas. Jadi BPJS tidak ada lagi kelas 1, kelas 2, kelas 3, satu kelas. Nah, ini memang masih digodok Bapak Ibu, jadi saya juga tidak bisa ngomong sampai terlalu clear, tapi pemerintah, Ministry of Health, apa sih yang pemerintah mau? Pemerintah mau bahwa BPJS itu yang nggak naik kelas. Ya, kalau dia menggunakan insurance yang public insurance, ya dia should increase in kamar rawat inap standar. Harus di situ. Kalaupun mau naik ke kelas yang lain, dia COB misalnya, ya segala macam. Tapi kalau BPJS ya dia tetap harus pakai kris, karena itu memang asuransi fasenya adalah gotong royong, seperti itu. Jadi ini memang kita sekarang lagi kejar, ini baik rumah sakit swasta ataupun rumah sakit pemerintah. Lanjut. Nah, kemudian tata kelola rumah sakit ya. Ini ada contoh-contoh saja. Maybe you can see the left side and the right side. And the left side itu adalah sesuatu yang mandatori yang we should do untuk rumah sakit. Jadi kita mesti mengerjakan bahwa ada 4 hal yang rumah sakit memang harus selalu ingat. Pertama adalah pengalaman pasien itu, patient satisfaction, kemudian high quality of health services, measurable health service output, dan efisiensi dan effective management. Jadi sekarang mengapa pasien itu bisa memilih, karena semua adalah pengalaman-pengalaman pasien. Jadi Bapak Ibu, dengan berbasis kompetensi, rujukan berbasis kompetensi, pasien bisa ke sana ke sini, ke sana ke sini, even itu pasien BPJS. Jadi pasien kita harus mempunyai meng-create a good patient experience, seperti itu. Jadi kita harus meng-create pengalaman pasien yang baik kalau di rumah sakit kita. Yang sebelah kanan itu indicators by hospital. Itu just example for us about the indicator for hospital. Kemudian high quality health services, about the doctor, about the nurse, everything about the human resources, how they service the patient. Kemudian measurable health services output. Nah, ini penting Bapak Ibu. Dulu kita diakreditasi, kita sudah senang kalau kita patuh ya kepada pedoman praktek klinis, patuh pada clinical pathway, kita sudah merasa cukup untuk itu. Tapi sekarang kita rupanya nggak cukup. Kita harus punya output klinis yang sudah kita deklarasikan, declarekan. Ya, kalau misalnya our Center of Excellence in kayak Mr. Iwan jantung gitu ya. Pak Iwan itu mesti pastikan misalnya mana ya, yang neuro yang mana, yang kardio yang mana, door to balloon time, ya itu harus dideklarasikan door to balloon time. If the hospital is a center of excellence in neurology, you want to make hyperacute stroke patient undergo non-contrast head CT scan under 30 minutes. Seperti itulah. Jadi kalau orang datang ke Ngurasan, apa yang bisa didapat? Kita harus berani mendeklarasikan. Kita nggak just compliance itu sudah lewat fasenya, fase kepatuhan itu adalah sekarang pasien pingin ada output yang mendukung untuk itu. Apakah ini mudah atau tidak itu ya tergantung rumah sakit. Pokoknya rumah sakit kita cerita tentang berbasis kompetensi. Makanya kami selalu menganjurkan hospital itu make sure what the center of excellence. Jadi make sure. Jadi yakinkan bahwa unggulannya apa. Kemudian efektif dan efisien, kalau swasta is no issue lah ya. Swasta kita udah tahu bahwa pasti private hospital is so efisien, so efektif, dan rumah sakit pemerintah belajar kepada rumah sakit swasta untuk itu. Nah, rumah sakit pemerintah sekarang sering dikritik ya, rumah sakit vertikal terutama Kementerian Kesehatan dibilang bahwa sekarang bergerak. 2 minggu yang lalu saya baru webinar yang judulnya menyelekit Pak Yudi, judulnya Government Hospital from Care to Cash. You know, from care to cash. Ampun dah. jadi sekarang kan harusnya tidak berbeda ya. Hospitalnya itu tidak berbeda dong. Kita bergerak di regulation yang the same regulation. Memang kita mempunyai masing-masing tugas tapi rumah sakit pemerintah, government hospital memang not for profit ya. Tetapi it doesn't mean no profit gitu loh. Ya, kalau Bu Okti no profit, udah lama Bu Okti nggak jadi dirut. Ya Pak Muhadi, ya government hospital I agree is not for profit. It's okay, but it doesn't mean no profit. Ya, jadi jangan dibilang government hospital forward to care to cash. Bayangin gua diskusi 1 jam sama orang gituan. Jadi seperti itu ya. Jadi rumah sakit pemerintah pun kita banyak belajar dari rumah sakit swasta. Kita banyak belajar ya. Kita banyak diskusi untuk itu mana yang bisa diadopt ya. Cara mengelola rumah sakit yang efisien dan efektif. Jadi makanya teman-teman sekarang itu di RSUD dan di rumah sakit Kemenkes itu juga belajar untuk itu. Slide selanjutnya. Nah ini best practice performance measurement of hospital. Kalau rumah sakit Kemenkes sudah setiap hari dikejar-kejar, ya itu semua belajar dari teman-teman swasta kok Pak Yudi. Ya jadi kita nggak usah malu. Government hospital juga belajar ya from private hospital. Jadi kita saling collaboration. Nah private hospital juga banyak belajar dari rumah sakit pemerintah tentang ketersediaan human resources ya. Itu kita kolaborasi karena kita tidak ada lagi rumah sakit yang do all everything. Jadi kita hanya bisa collaboration satu persatu. Lanjut. Nah, ini slide saya yang terakhir Bapak Ibu. Jadi implication for hospital apa? Bahwa hospital itu ya memang harus punya center of excellence. Jadi kita ingatnya apa misalnya? Ke rumah sakit A kita ingat ini. Ya nggak ada lagi palu gada lu mau gua ada itu nggak ada lagi karena semua berbasis sekarang kompetensi itu. Tapi ini nggak is okay lah, pelan-pelan kita transisi untuk itu. Ya kami mendrive karena kedepannya tidak ada lagi rumah sakit khusus dan umum, yang ada itu rumah sakit dengan keunggulan. Kalau dulu dia Pak Iwan jantung ya, berarti nanti keunggulannya jantung, keunggulannya ibu dan anak gitu loh. Ya, tetapi Pak Iwan bisa ekspansi ke layanan lain seperti itu. Kalau mau, kalau nggak mau nggak usah Pak Iwan. Concern ke jantung saja. Nanti Pak Iwan pusing. Tetapi regulation mengizinkan untuk itu, gitu loh. Jadi tidak ada lebih kaku lagi. Buktinya Ngurah bisa punya private wing yang cukup bagus kan? Ya, yang tiba-tiba Ngurah itu kok identik dengan estetik gitu loh. Ya kan? 10 tahun yang lalu nggak tergambar seperti itu. Kemudian rumah sakit harus menghitung semua unit cost ya, efisien, efektif, tidak bisa lagi walaupun itu government hospital. Nah, non JKN executive health services itu menjadi pilihan juga Bapak Ibu. Ya, jadi tidak ada lagi bahwa government hospital itu harus hanya melayani pasien JKN. Itu tetap menjadi tugas kita, tetapi memang bukan itu satu-satunya. Jadi kita juga harus memikirkan non JKN. Jadi di luar dari pasien BPJS kita juga pikirkan. Ya, jadi teman-teman semua antara rumah sakit pemerintah, terutama yang di Kementerian Kesehatan dengan yang di swasta, kita sekarang sudah mendekatkan itu, Pak Yudi. Jadi rumah sakit swasta juga bisa have a teaching hospital, research itu juga bisa. Ya, banyak kok rumah sakit yang sekarang sudah punya clinical research unit yang bagus. Ya, dan sudah lakukan penelitian dan sudah menjadi rumah sakit pendidikan. Apalagi nanti beberapa bulan atau mungkin nanti kita punya rumah sakit penyelenggara PPDS dari swasta misalnya. Itu sudah menjadi keniscayaan. Kemudian yang keempat bahwa information technology itu harus kita pakai. Ya, mungkin after my session Pak Aji nanti akan cerita so many about information technology, how hospital to do it. Kemudian yang terakhir, bahwa kita harus menentukan indikator-indikator yang baik ya untuk financial and operational indicators. Jadi itu yang harus kita lakukan. Slide berikutnya. Ya, saya kira itu yang bisa saya sharing ya. Not so many sharing, but I think it's an important thing we have shared to you. Our government policy forward to hospital policy. Thank you. Selamat pagi. Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih, Dr. Sunarto. That was really inspirational. Sorry, could I invite Dr. Sunarto up on stage, please? We'd like to thank you for your inspirational speech and give you a token of appreciation. The transformation that you are conducting within the ministry is commendable. You know, what I did see was that you're putting patients at the center in terms of the care delivery reform. Right. Thank you once again, Dr. Sunarto. From the vision of transformation, now we go to the next topic, which is very close to my heart, which is digital transformation. So we have the pleasure of Mr. Setiaji to deliver the transformation messages from the ministry. I've heard you speak before at HIMSS and various other organizations. You're a global speaker, we know that. You're a leader in digital transformation within healthcare in Indonesia. We have the pleasure to please ask you to come up on stage.
Yeah, thank you. Maybe I will follow Pak Sunarto, yeah, not in the state. To make sure your neck's not stiff or sore, so I will in the center. Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. Good morning. Salam sehat, salam sejahtera untuk kita semua. First of all, I would like to thank you for the Global Health Asia Pacific, especially for Global Health Indonesia happening to me today. Yeah, I believe all the panelists, all the audience agree. The digitalization in the health sectors is necessary and also important. Not only to make sure your hospital operational more effective and more efficient, but also the important thing is how we can make a big impact using the technology to make our people more healthy. Yeah. Yeah. We learn a lot from the COVID, how the technology is very important to eliminate the COVID, yeah. Not only about the digitalization, but also the health technology like genomic, and etc. Because of that, Indonesia learned from COVID. So actually we start the journey during the COVID to develop what we call the Peduli Lindungi. Actually it's very hard to spell the Peduli Lindungi, yeah, to fight the COVID and then integrating not only the health sector industry but also many industry like transportations. But we know many issues and many challenges when we implement the health digitalization, especially in the hospital. Not only in terms of the human resources, infrastructures like internet access, especially in the remote area, etc., But and then the important thing also the doctor itself, especially the senior doctors. Yeah, because of that, but we still believe it can be heaven. Not only maybe not now, but maybe in the next years. Yeah. Yeah, we still issue about in Indonesia we have more than 280 million people. You can imagine it's very big issue about that. And also Indonesia have more than 17,000 islands, and then spread in the I think more than 5,000 human life people in their islands. And then also we have some issue about the application itself. Too many applications input in each hospital. For example, in the primary cares we have 60 system to input for the health sector, for the health workers. And then also the hospital more than 50. Because of that, our aim is how we can collaborate within the hospital, within the PPGS, and every sectors, telemedicine, startup, and etc. to on the right side. We develop what we call the Satu Sehat platform. Actually, the Satu Sehat is health information exchange. Yeah, we put in the standards, the global standards like ICD-10, ICD-9, etc. to make sure all the health facility can integrate, and then so the doctors can check the historical medical records coming from its different hospital. And then also we have some initiative. Our aim is how we can combine the clinical data and also the genomic data to develop more precise treatment for our peoples. And then also, because we also have another ecosystem like a startup, and then the important thing also to make them grow. For example, like Halodoc, Good Doctors, etc. And also, I see here, Bu Robin coming from the Go Apotek. So we put in the sandbox to make sure they also can grow, and then our regulations can adapt with the current situation. For example, like telemedicine, marketplace online for the drugs, etc. Yeah, this is our journey. So we start in 2021 during the COVID. So and then after that we launched Peduli Lindungi. Peduli Lindungi, more than 100 million people use these applications. And then end of the 2021, so we start to launch our blueprints, the first blueprints, till 2024. We're still finalizing our blueprints, and then we will launch on the April after Lebaran. Yeah, our blueprints will we will publish 3 documents. First about the strategic levels, and then the second is a roadmap. Every year we will put in some prioritize, and then also the costing. And then also another partners can involve in our blueprints. And then the third documents more technical, like enterprise architectures for the health ecosystem, not for Ministry of Health, but the health ecosystem to integrate it with us. For example, for insurance, how they can develop the system to develop the claim system, because currently, because I also, as a patient, sometimes need more time, especially in the Saturday, because not have many people to serve you, especially for the claim. We need more than 1 hour, 2 hours to waiting the claims is approval by the insurance. Because of that, it's very important thing to develop the digital and claim system also. And then in 2022, so we launched in July, we got this Satu Sehat. Satu Sehat platform, we put in the standard, to make sure more than, because in Indonesia we have more than 1,000 vendors. They sometimes the hospital they develop by own, and also sometimes they use some third parties, to use this hospital applications. And then after this, along the way, so we start to integrate it, and then launch the regulations to put in the mandatories for each hospital, each health facility to connect with us. So currently now we already have national medical records coming from the 40,000 health facility, not only from the hospital, primary care, clinic, private doctors, laboratories, and soon from the midways. And then after this, so we transition Peduli Lindungi to Satu-Sat Mobile. So the citizen now can access your medical record from Satu-Sat Mobile. Satu-Sat Mobile now is also used for our quick win programs, for the free health screening. So yeah, I invite you, I ask for the Indonesian people, especially to download the Satu-Sat Mobile, because you can register using the Satu-Sat Mobile to have the free from the government for the health screening. Yeah, this is our achievement till 2024. So after our minister, our minister is very determined people, every day always ask me about the progress, especially for the digitalizations. This is our ecosystem. We already have the ecosystem. We call this Satu Sehat, not only the platform, but also the important thing, we also have some another products. For example, for the logistic, Pak Sunarto mentioned before about how we need to integrate it from the planning, especially for the medical devices, drugs, till utilization. Because we still have some issue. We already buy the medical devices, but sometimes we don't know this is optimized or not when use these medical devices. So we will develop what we call the Satu-Sat logistic. Actually, this pure of the supply chains. And then the application, this is the integration result coming from the facility. And then the left side is health sandbox. Yeah. Currently, we already run the 2 batches. First batch is telemedicine. Soon we will launch the new regulation for the telemedicine, because until now there is no regulation for the telemedicines. Yeah. To make sure they can cover also from BPJS and also direct from the patient into using the telemedicine, especially for the remote area. And then the another batch is, for example, like medical devices, online marketplace, patient solutions, and many things. Yeah, and then this is another achievement. So on the left side is this is the application used by the cadres, especially in the Posyandu, the community health workers, the community health facility, to input like screening, immunizations, mothers, and also the baby, because the nearest health facility actually the Posyandu. The Puskesmas sometimes is very long, it's so far, from the people itself. And then in the middle is we also currently use the WhatsApp, because I think the biggest application used in Indonesia is WhatsApp. In Indonesia, it's very unique. Usually not see the email. So if you want to contact us or contact me, use the WhatsApp. I very seldom to use the email. Currently, mostly in Indonesian people use the WhatsApp. And then in the left side is the Satu-Sat Mobile. Currently, the active users is more than 19 million users. We put in the electronic medical resumes, also the health screenings, some screening, and also currently connect with the Apple Watch. So our aim is how we want to give you like incentive, like in the Singapore, you have Lumi. Yeah, we will do the same. Yeah, and then of course, the data itself. So you can see the public's data into our dashboard. Yeah, the dashboard itself not only can use by the clinicals, by university, by industry. You can use this, and then you can access and make some analysis, to support us. Sorry. Yeah, and then to continuing our journey still continue. So currently we have some programs. Yeah, this is our Satu Sehat programs. So as I mentioned before, we already have Satu Sehat platform, and then currently we will develop the Satu Sehat logistic, and also soon we will publish the receipt, e-prescription for all industry. Yeah, and then this is the Satu Sat platform itself. Yeah, actually we put in some standards into there, and not only international standard, but also our customized standard like medical devices reference, etc. And then the doctor itself, we already doing the piloting for doctors to access medical records is coming from different health facility. Yeah. We will roll out these medical record portals to all the doctors in each hospital, also from the, for example, like HaloDoc, telemedicine, so they can also access your records coming from different hospital. Of course, we also concerned about the PDP. Yeah, we need consent, yeah, to access your data. Next slide, and then this is, I spill a little bit, yeah, about our next journey. Actually, our vision, our mission will support all the health indicators will be achieved on 2029. So our mission, not only building a connected health facility, connected health data, and then also we ensuring how we can make sure efficiency, effectiveness, our operation, etc. Our aim is not only we get the data and then we know how many people sick today, but the important thing is we will it can be answers, for example, how many people more better or died after do some treatment. This is our aims. Yep, in the 2029. Because of that, it's very important thing is clinical pathway, follow up, etc. Especially for referral system, yeah, using the competency base is very important thing to do that. And then the next thing also to improving the culture of data, because as you know, health workers, not too many health workers is knowing about using their data. And then the next thing is about to develop the innovation and collaboration. Actually, we have 3 sandbox. First, the regulation sandbox, regulatory sandbox, and then the second thing is industrial sandbox, like in the Singapore did by the Temasek. And then the third thing is about the innovation sandbox. So we will invite any kind of the startup from the international to give us some solutions, yeah, for the TB and then for the general common issues in the health. Yeah, this is what we want to hear here in 2029. Yeah, not only the effectiveness, the how many people more better, etc. And then the important thing we put in the health, yeah, not in the life expectancy, but the health efficiency, etc. And then this is our some quick win program in 2025. So we already launched, I think 3-4 days ago, yeah, to get not only the sick people but also the health people. After this, we can have the populate-based data for the health people and also the sick people. For the 280 million people, I think this is the biggest programs after the COVID in the Indonesia. So I ask and remind for the Indonesian people to download and register the Satu Sat mobile, and then you can eligible after birthday till 30 days. Yeah, 30 days after birthday. And then the another biggest program also to about the TBC to make zero in 2030, because as you know, Indonesia is the second biggest for the TB cases. Because of that, it's very important thing to develop end-to-end system for the tracing, for the treatment, and also for the testing itself. Yeah, because of that, it's very important thing involving all the side in this meeting room to support the TB eliminate in Indonesia. And then yeah, we're talking about the AI. Yeah? Because of that, currently we already have the task force AI. Eric Tenda is one of our members to make regulations and also to make some use cases. Currently, ongoing piloting in the 3 hospital in the Jamil, Jamil for the lungs, for the lung screenings using the image radiology, and then for the pathology in the dermis, and then for the brains image using the AI. Yeah, and then we also have some tools for the malaria predictions, also for the diabetes, etc. So we hope we can optimizing our data, because currently we already have 1 million prescription in our database, and then also more than 300,000 images in our system, and then also more than 300 millions encounters in our data. After this is how we can optimizing our data using the AI. Yeah, I think this is from my side. Thank you. I hope you can enjoy and support for us. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Mr. Setyaji, for wonderful transformation within digital. And congratulations on your achievements so far from 2020 onwards. So as a token of appreciation, if you could come up on stage, please. I think Mr. Yudi is outside, so I'll take the honor of giving you the token of appreciation. All right, that brings an end to the morning session before our coffee break. So we are right on time. Can we please come back here at 11 o'clock on the dot to start our next parallel track session? So after the coffee break, which is outside, we'll have 2 tracks. One on this side, which is the track related to global health, and on the other side, we'll have the NUS track. So please come back after 20 minutes. See you soon. Thank you.
and manage hospital bed capacity, the National University Healthcare System launched a virtual ward program that allows stable patients to be discharged earlier into their homes. These patients usually Welcome to Singapore, a tiny island city-state in Southeast Asia with over 5 million people living across a densely populated island. Today, Singapore is home to a rapidly healthcare system launched a virtual ward to be discharged. AI-powered patient monitoring platform that connects doctors and nurses to their patients through popular chat platforms.
Okay, good morning, everyone. Thanks for coming for Health Hack today. So my name is Jonathan. I'm part of the team at the National University of Singapore's Digital Advanced Technology Accelerator, coming to you from the Yong Loo School of Medicine. Today, we're coming to you live in person and live stream from Bali, Indonesia. And today is the kickoff of our Indonesia edition of our Health Hack 2025. So I say Indonesia edition because last Saturday we had our Singapore kickoff where we had, I think, over 1,000 participants because we don't know the exact number because our live stream crashed last week because it got overloaded. So hopefully those of you watching from home will not get cut off today. We provided the bandwidth, so fingers crossed. Thank you all for joining us in person and making the trek all the way down here to sunny Bali. And thank you to those of you who are joining us virtually online. Really wish you could have been here, but glad that you could join us virtually nonetheless. So what is Health Hack? Health Hack is essentially the School of Medicine's premier hackathon. It's aimed at seeding, inspiring, and growing the next generation of health technologies, right, with a commercial lens. And what we have today lined up for you is an excellent panel of speakers. First and foremost, to help you understand the health problems that we need to solve in the market. And secondly, to teach you how to build and commercialize technology solutions in this challenging space, right? So we've got a great lineup of speakers, but today is just the beginning. At the end of today's sessions, there will be two excellent briefings on the competition itself, the prizes, and what's up for grabs. We then have a 6-week period where you get to build your pitch and your prototype, and then we've got finals over in Singapore. So those of you, wherever you are, if you do make it to the finals, we'll bring you down to Singapore with caveats to join our finals, right? So we look forward to all of you and your submissions, not just for the talks today, but also your submissions and your engagement over the next few weeks. So I'm just gonna, do a little bit of marketing here. Follow us on our various channels. Just give you a second. There's gonna be a series of like 5 QR codes that I'm gonna get you guys to scan before we dive into the talks. Okay, so those are just some of our socials. There is the live stream, which is happening right now. Those of you who want to view the Singapore streams or the Singapore videos from last week, you can also follow us on YouTube. Those should be up there as well. And quite importantly, for those of you joining the challenge, please do join our Telegram channel. It's where all the competition announcements go out, all the workshops that are coming up, on how to build on certain infrastructure platforms come up. And last QR code, those of you who want to form a team or want to join others to form a team, we've got a Trello matchmaking board where you can network with others to find a team to build a solution together. So one last announcement. I just want to thank our partners at InterSystems and Global Health. InterSystems, they're speaking today, and they will give you a great introduction on how to build on their platform and the great technology and the great data that unlocks, and also Global Health for having us here today at Bali. Okay, that was a lot of ado, but without any further ado, I'd like to introduce our first speaker, Mr. Sutowo. He's the director of the Health Analytics Division at the Ministry of Health Singapore, and he's here to tell us how to improve healthcare with data.
Hi, good morning, everyone. Hope you had a good tea break or coffee break. I'm Sutowo here. I lead Health Analytics Division in Singapore, Ministry of Health. One thing that people has been asking me, I've done quite a fair bit of sharing. Many friends from different parts of the world are quite interested in how Singapore is using data to improve healthcare. I've done sharing with the government in Indonesia. I've done that with government of Brunei. I've done that. Recently, I hosted someone from the Beijing Health Commission, the Municipal Health Commission. I've done sharing with UK, with Australia, even with Peru. But that was online sharing that I did. So quite a few people have been asking, how is Singapore actually using data? And here I'm going to give you a bit of a preview, a bit of a inside view of how we look at data. I'll start a bit on the operating context, which could be different in Indonesia and many countries in the world, but globally, many of us are facing very common challenge. One is aging population. In 2010, 1 in 10 Singaporean is actually 65 and above, and is projected to go to 1 in 4 in 2030. And what we have found is that seniors use more healthcare services, they are more likely to be hospitalized, and when they do go to the hospital and get admitted, they stay longer. Rising prevalence of chronic diseases, that's the same, I think, in many other countries as well. Our DHL, diabetes, hypertension, hyperlipidemia, those are actually trends that we see globally as well. Of course, with that, the complications create a lot of consumption for downstream healthcare services as well. Finally, we have very finite manpower, especially a small place like Singapore, not enough people, which is why we have to actually bring quite a fair bit of foreign talent into Singapore. Even then, that is never enough. And from a financial standpoint, it's also very difficult. It's getting more challenging. COVID wiped out our budget surplus for the last 30 years. Singapore is one of the few places in the world that has budget surplus for the government, but even then, COVID wiped out 30 years of surplus. So we need to look at how we can do more with less. Some of the shifts that we have embarked on, essentially moving the center of gravity from acute to the community. Today, Singapore's healthcare system is still very acute-centric, focused on the acute hospitals. A lot of the resources actually goes there. But increasingly, we are moving towards community care, towards primary care, looking at how we can care for patients out in the community, and not only that, going into preventive care. How to do more screening, vaccination, keeping population healthy. And to do that, data plays a very big role, and so is technology. Because the underlying premise to which all these initiatives, for it to be successful, really is around behavioral change. And what we are trying to do is to drive behavioral change. What do I mean by that? If you go to a primary care doctor today, at least in Singapore, right, most of the time, why do you go there? I have cough or cold, I need MC, right? MC stands for medical certificate. With that, you can take sick leave. Right? So if I go to a primary care doctor, the first thing I think about is I want to get an MC. So what we did is to create this thing called Healthier SG, which I'll go a bit into later, where what we want to do is to change people's behavior. First the mindset, then the behavior. You go to a primary care doctor, not just when you are sick. Even when you are healthy, we want you to see a primary care doctor. Why? We want you to have a health plan that you develop for yourself together with the doctor, so that you focus on the right things that will help you improve your health. And what are those things? Having enough exercise, having a good diet, having enough sleep, doing your vaccination, do your screening. All these are things that has to be done. So we are changing people's behavior, and with that, we need to know about people first, right? What is their current behavior, and then how do we change that? We work with many different partners, both at the national and the regional level. We work with other ministries, for example. We work with our Ministry for Social and Family Development. We work a lot with them when it comes to underprivileged population in Singapore. We look at the bottom 20 in terms of income. And what we want to do is to look at health outcomes for families, what we call the B20 families. How are they doing compared to others? Do they need more help? And if yes, help in what area? Take, for example, are there certain conditions that are more prevalent in those families than others? And if yes, why? Are there things we can do to help them to improve the health outcomes? We also work with others, early childhood area, working with AGDA, working with Ministry of Education as well. Of course, then we work with community care partners. We work with also active aging centers for our seniors. These are the two national initiatives. The latest one being Grow Well which is targeted at the children. We have done that, was started with Healthier SG, which is for 40 years old and above. And then we have Age Well SG, which is for our seniors, 65 and above. We have some hypotheses, like for example, for Age Well, really, I spoke about Healthier SG earlier, but for Age Well SG really is, we want to try to see how we can help seniors who are facing challenges of social isolation. How do we help them get connected to the rest of the community? How do we get them to go into senior voluntarism, for example? How do we get them to be more active in their lifestyle? So to do that, right, we have to have strategy, right? A lot of times, I was a consultant in management consulting. Strategy seemed very complex, but if you break it down, it can be quite simple. It's about two things, right? Where to play, how to win. And the way where to play bit is important to connect back and look at the context for you, for your organization, for the industry as a whole. Are there some demographic shifts that you're seeing? What does that mean to you in your sector? What does that mean to you in your organization? I covered a bit earlier about aging population, rising prevalence of chronic diseases, and having finite manpower and financial resources. These are things that are there. To us, I call it our demographic destiny. Is there demographic destiny that you can't avoid? And therefore, having to confront that, what does that mean for your sector? What does that mean for your organization? Important to think about that. And therefore, we go back to that and look at what are the health system goals. And to achieve those health system goals, what are some of the objectives that we want to achieve? What are some of the use cases that we want to focus on? Very important. What are the things that you want to focus on? You prioritize it and make sure you tackle the most important things. So that's where to play, right? If you have a laundry list, everything you want to do, that is not strategy. That is just a laundry list. Strategy means choice. You have to make choices, and therefore what's most important? How do you prioritize? The how to win part is, when you run use cases, you tend to start with a pilot, with a proof of concept or POC. It may progress to proof of value, and eventually you want to scale it, maybe at a national level. And to do that, you need enablers. Enablers such as having proper data governance so that people are not too afraid to innovate. They are not worried about breaking rules. The rules are clear so that people know when they are actually going ahead and do something that is not breaking the rules so they can move faster. AI governance, IT infrastructure is absolutely important because there's also a stumbling block for many people who are looking at innovation. After the POC, they can't integrate back to all the major systems in, say, for example, their hospitals. So having some of these things up front, the thinking up front, the planning up front, involving IT professionals at the start, not just with the clinicians, is actually important to ensure that you have a better pathway to mainstreaming or to scaling at the national level. Some others like data education. How do you make sure that the people who are giving you the use cases know how to make use of the data? Because I can tell you, as someone who is doing data for quite some time, when I talk to my business colleagues, often because they do not know data, they do not know what's possible. And therefore, it takes a while, a back and forth, right? Do you mean this? Do you mean that? We sharpen the problem statement. As you then embark on the process to uplift the data competency for everybody, not just your data practitioners, it helps. People knows what data can do. They know, more importantly, what data cannot do. And therefore, the problem statements are sharper. And you then get to the business more quickly. There are other things like funding. For example, a lot of my colleagues in the public healthcare institutions rely on research grants. But the thing about research grant is that it doesn't cover IT integration. You can build whatever POC, and later on when you need to integrate with the system, you need to deploy it to production. What happens? You need to do your penetration test, you need to make sure that it meets your cybersecurity rules, right? All this costs a lot of money. And the research grant doesn't cover that. Where do they get the money? So there has to be some bridging fund that helps our innovators. The most promising innovation in moving through that chasm between your innovation and production deployment. So it's important for us to recognize that there are challenges and therefore putting aside enablers that allow us to help them. But is strategy enough? Often you can build, for example, many dashboards, right? I have dashboards about hospital capacity, what's the waiting time, the queue to go to the emergency department, the queue for admission, how many beds are available. All these are good, right? But who's using them? Sometimes not many. And how do you then get people to use it? It's as simple as your senior management asking questions. So give you a case in point. We have been building dashboard in the ministry for the longest time. And all it took was for our deputy secretary to say that, I want to see this dashboard every month at the management meeting. And I will scrutinize the number. You have to explain to me why the patients are waiting so long. You have to explain to me why there's a choke point between the hospital, the acute hospital, to the community hospital. Why are patients not discharged to community hospital? Why there's so many U-turns back to acute hospital? And once he starts asking all these questions, people pay attention to the dashboard. Not only pay attention to the dashboard, but they actually go and find out the root cause of what you're seeing in the data before the meeting, so that at the meeting they can explain why, and to say that I have taken action. So the culture part is absolutely critical, because you can have all the technology, you can have all the best strategy, without the culture to support it, nobody is going to care. So we have to bear that in mind. And in healthcare especially, if you look at a healthcare institution, a hospital, for example, I was told by someone who is very senior that actually medicine is an apprenticeship. And that means then that it's not quite intuitive for a doctor to look at the data. You learn from your seniors, your mentors, and they are very differential for a good reason to the senior doctors, right? But how many cases can one doctor see in a lifetime? Not that many, depending on the conditions, of course. But if you have the benefit of learning from all the data through the use of AI, that is very powerful. As a companion, as someone whom you can actually interact with, especially if you're a junior doctor. So thinking about AI, thinking about data in this way helps, because it's no different from having a mentor who is very experienced, who can help you with many of the questions. Of course, not everything is correct. Sometimes you need to verify, but it gives you a very good starting point. And it's having that mindset shift that's important, because otherwise, in an environment where it is more about like a craftsman learning from the master, it's not very intuitive to look at data and to get the insights from there and make changes to your practice as a result of that. So that one is actually absolutely critical. I'll give you examples of use cases, one of which this is segmentation. It's quite common in many industries out there. In fact, when I was in consulting, I worked with retail, for example. I worked with telco, I worked with airlines, where they have a frequent flyer program. We did a lot of segmentation. In healthcare, unfortunately, so far, I see mostly segmentation using demographic attributes, like, for example, age. Quite rudimentary. We don't looking at clustering or arriving at natural groupings of the population using all the data that you can find. In this instance, what we have done is we use not just the demographic, but the healthcare utilization, the health status, clinical outcome, even down to some of the exercises that people do and things like that. And using all these attributes, can we let the data speak for itself? Can we let the data tell us what are the natural grouping of the population? And what we have found, there are some interesting findings. Not conclusive yet, but good places to start. Take, for example, patients who have comorbidity in the form of mental health condition tend to do badly compared to others who do not have mental health condition. And again, if you look at patients with disability, for example, the outcomes are not as good as those without disability. Those are good places to start. We do not have conclusive answers yet, but it allows us to then dive into the areas that are useful, that will hopefully move the needle in terms of helping our population improve their health outcomes. This is how we look at service planning. We look at the projection of future healthcare demand. And where do we start? We start with risk factors, right? The risk factors, obesity, blood pressure, all these things. What does the risk factor tell us about the prevalence of diseases in the future? Because the diseases are actually usually as a result of the risk factors that are not well managed. And the diseases that are not well managed will result in consumption of healthcare services, especially the acute ones later on, if someone wait too long and not manage it. And consumption of healthcare services means then that we will need to provision infrastructure. Do we have enough hospitals? Do we have enough primary care facilities? Do we have the manpower? Do we have enough doctors? And if yes, in what specialty? Do we have enough nurses? Globally, we have a shortage of nurses. How do we make better use of the nursing manpower? How about other professions, allied health, pharmacists? How do we know whether we have enough of them? And all this has to be informed by data, by looking at the future healthcare demand that we are likely to see. And broken down into geographic areas. Singapore is small, but even then we break down to geographical area because we want to know whether there's any local mismatch between supply and demand. And using that, help us look at where we want to build new healthcare facility. For example, we want to build a new hospital. Which is the best site that will improve the coverage for the patients who are going to the hospitals. Of course, last but not least, it's not just about the infrastructure will need money to build. To train manpower, you need the money. So how do we use that to project our budget, right, so that then we can go to our Ministry of Finance and get the money. We have just concluded our 5-year block funding exercise where we got money for the next 5 years. And that is actually important input for us to actually do our planning. This is diving a bit deeper. This is some of the screenshots here are based on a tool called ePlanner. It is something that we build together with URA, the Urban Redevelopment Authority in Singapore, where they look at land use and the planning. And what we do then is to put healthcare data in ePlanner for us to be able to visualize where population is, and not just population in terms of their simple demographic attributes, but also looking into healthcare consumptions, utilization, looking at then matching that against the supply at a local level, down to how many minutes does it take for someone to reach a particular healthcare facility, for example, using public transport. And do we have enough coverage where the mismatches are, not just where population is, but also where people are consuming healthcare services. If you take a persona of someone who's looking at health services planning, what you can do is to dive into where the demand is. If you look at the screenshot here, the darker shades of red essentially is where there's a higher concentration of your population of interest. In this case, you can look at different things. For example, people who are suffering from diabetes. You can even look at whether or not these people are the people who have poor control of their diabetic condition. Do they have low follow-up rate when it comes to going to the primary care? Do they have other conditions that are not well controlled as well? And then you can then look at the facilities, where the facilities are. First, where the patients are, where the demand is, where the facilities are, where the supply is. And then you can see, if you draw a buffer zone, for example, in terms of how long does it take for someone to travel to a healthcare facility. It can be 5 minutes, 10 minutes, 20 minutes. Then you can see how do you improve access, how do you improve accessibility of the healthcare facility. Do you want to, for example, offer some shuttle bus services to make it easier for people to actually go to these healthcare facilities? So that's how we do service planning. This is Project Pensive. The whole idea is how can we better detect cases of dementia out in the community. The standard test here actually requires literacy level of our seniors. Unfortunately, not all our seniors have the opportunity to actually have formal education. Some of them may not be illiterate. And therefore, this idea is that can we show a series of pictures using tablet, and then the seniors are asked to replicate those drawings in the same order that they are shown. And the extent that they can or cannot do it will give you a score as to their likelihood of suffering from dementia. And using that, we can actually improve access, go out to the community, because you no longer need train a healthcare professional. You just need to train someone on the use of the tool, and the senior doesn't have to be even literate, just looking at pictures. And that actually improves the time that it takes for us to be able to detect such cases out in the community. And we also want to use digital technology to bring, in a way, quote unquote, the clinics or the healthcare facility to the population instead of having them to come to us. Just now I talk about access, I talk about how we do service planning. Of course, we try to make it as easy as possible for someone to be able to access healthcare facilities. But that may not always be the case. Like I said, a patient with disability may find it a bit harder to go to the healthcare facility, for example. And therefore, having digital technologies that allow them to be able to see healthcare professionals through teleconsult, for example, or to take their blood pressure reading, Bluetooth-enabled devices that help them then sync with their phone, and they can send the data to their doctors who will do the review. All this make it even more easy. And some other technologies, like for example, if you do go to a clinic, can the transcription be done automatically so that you don't have to then key in all this information, or the doctors don't have to key in all this information into the system. That helps to cut down the time and the doctor to focus more on the patient. Then on enablers, right, we'll talk about the use cases. How do we make it easier for the use cases to succeed? Sorry. This is about the teaming. How do we get the right people? It's not just about having data scientists. You need to have people who can actually work with the clinicians, for example, translating what they need in terms of business use cases or the problem statements into technical terms for a data scientist to work on. You need data engineers who are able to build data pipelines to make it scalable. You need people who are able to design the UI UX so that whatever that you build is easy to use. And there are people who want to adopt the tools, for example. So it's a multidisciplinary team who has to work together to realize and make it happen. Of course, there's data education as well, where you need to then see how do you uplift the competencies for everybody, not just data practitioners. So we do have different personas where we actually do have training courses. First, competency framework. What are the competencies that they may want to build? And then tied to the competencies are the training courses. Not just any courses, but curated list of courses that we have gone through and we think is good, that can allow them to actually meet the competencies. This is about AI governance. It's very important for us to look at that. Very often you see principles, right? Fairness, transparency, explainability. Question is that how easy it is to implement based on those principles. How do you improve, for example, transparency? How do you improve fairness? Not very intuitive, right? So what we did was to look at the life cycle of a project. At the start, if you look at the data, is your data representative of the population for which the AI system or solution is going to benefit? If you build it on a subset of the population, it may not actually be relevant for the other population for which the model is not built on. And therefore, the accuracy will actually deteriorate, or actually it will suffer because you are not using it for the intended purpose. So that's at the start. And after you have built the model, you deploy it, you have to monitor, right? Because the AI system or AI solution or AI model will deteriorate over time as new data comes in, as new patient data come in, well, for which the model is not trained on. And therefore, you realize that there's a deterioration. We have to then look at a threshold. The banks does it a lot. They have thousands of models running, and then they actually look at then setting a threshold. And when it goes below the threshold, it's time to retrain the model so that you keep the accuracy up. And you don't keep continuing to use the same model and again, although it's no longer working as intended. So using the AI governance guidelines, what we want to do is to encourage people to think about all these things across the entire project life cycle. So that then they can see what are the things they need to look out for at every stage of the project. And finally, about accountability, it's important for us to look at how to account for the money that you spend. How do you prove that something works, right? Like I said earlier, research grant doesn't cover IT funding, and often if they want to mainstream in the Singapore context, meaning I want to have it be eligible for MediSave, which is part of our Central Provident Fund, which is compulsory savings that every Singaporean has. There is a healthcare component that they can use. Can I make it eligible for MediSave? Can I make it eligible for MediShield Life, which is our national healthcare insurance? To do that, they have to jump through a few hoops. We have to make sure that it is cost effective. And many of them at pilot stage do not know these are the things that we care about. And they happily complete their pilot, come to us, say, I want to mainstream. I'll look at it and say, hey, buddy, you didn't meet all these requirements. So you have to collect the data. And you have to spend another 1 year, 2 years to collect the data so that you can meet our requirement. Not a good situation. So what we want is to tell them upfront, this is our requirement. You may want to think about collecting this data upfront because, of course, there's a balance. Not every use case is meant to be scaled at a national level. Some are more niche, and therefore there's no need to do that. But for use cases that you want to scale eventually, you have the ambition, and you can see at the early impact, you may want to then start to think about how do you have all this data that allows you to demonstrate cost effectiveness, for example. I'll give you an example of what we have done in terms of evaluation. This is for pediatric care center. This one is, in a way, is a substitute for children's emergency, where we want then people to go to this UCC instead of going to the emergency department in the hospital directly. So what we have done is that we drew an 8 km radius because 90% of the patients who are going to UCC actually are within the 8 km radius. And then we look at comparing between the treatment and the control group. Here's how you see it. The treatment group at the top, control group at the bottom, and see over time, before and after UCC has been implemented, what's the difference between the two. So at the beginning, before it's implemented, the difference, there's already a difference. But after that, you see the treatment group, actually in terms of the gap between the treatment and the control group actually narrows quite a fair bit. And this is what we call difference in difference. It's quite a common technique in econometric, where we then find out whether or not there's indeed an improvement that we have made to the treatment group compared to control group. You can't look at just treatment before and after, right? Because you need to look at what would happen if you did nothing, and therefore the control group is important. So things like that are things you need to upfront tell people that you will need to be able to set this control group aside. You need to be able to collect the data and then demonstrate that, so that when they come to us, it is an easier conversation that we're going to have. So in conclusion, context is important. Make sure you look at the context of the organization, of the industry, of the country, or even globally, depending on your market. Strategy is about choices, where to play, how to win, use cases, enablers. And last but not least, accountability is important because you're always using someone's money. Whether the taxpayers' money, whether it is your investors' money, it's actually important for you to be able to demonstrate the accountability, and having robust way and methodology for you to do that will be important for you to prove that what you do is actually a good bang for the buck. That's all I have. Thank you very much.
Thanks, Ito. That's really, really enlightening. Really appreciate the things, what you've shared with us about how the government looks at data and how the government looks at health data. I'm going to open the floor to 1 or 2 questions. So, if anyone has a question, just put your hand up and I'll come over with the mic. Okay, if not, I've got a quick one. Oh, yes. Amazing.
Thanks a lot. So thanks a lot for your presentations. It's obviously really inspiring and really comprehensive. And I also am in Singapore for the last 15 years, and I'm always a big fan in a way of Singapore efficiency when it comes to healthcare, the rest of the domains, and I'm quite biased in a way. And every time I share the kind of, in a way, success stories when it comes to Singapore, the feedback is always, yeah, Singapore is a small country, 5.5, 5.6 million inhabitants. Could we really replicate that at scale when you're looking at the scale of Indonesia, some of the countries that we have, where you have like tier 1, tier 2 cities and so on. So to what extent do you think that what you have done with the team and all of us in Singapore, to what extent could we basically have some best practices that could be relevant in different geographies? Could we scale this approach, basically?
Thank you for your question. That's a great question. I think it's important to recognize that some of the things that work in Singapore because of its unique circumstances may not work elsewhere. So we have to acknowledge that, because in quite a geographically spread out nation like Indonesia, where there are a lot of differences from your tier 1 to tier 2 to tier 3 cities, it is not as straightforward. Access to healthcare is a lot lower. It is actually not like Singapore, which is quite densely populated, easy to access healthcare, and therefore there are differences. Infrastructure-wise, it's also different. But the way that we look at, for example, some of the enablers, for example, are the same enablers, making sure that you have the right level of governance so that people actually can trust what you do and you're doing the right thing. Having the right infrastructure is important. Today, I think because of the use of cloud technologies, it has actually democratized a lot of the difficult to build and scale technologies out there. And therefore, what we do in Singapore, I think, will also apply to many countries out there. In terms of that robustness that you need to achieve, you still need to be accountable to whoever is funding you, whether it's your investor, the government, taxpayer. Again, having a sense of what is the right approach or more robust approach to demonstrate the cost effectiveness is also important. But cost effectiveness then, in the context of Indonesia, say, and Singapore, or other countries and Singapore, may be different. There are two ways to look at it. You can look at outright cost savings, because sometimes you want to achieve cost savings, and therefore it's just a cost reduction that you're looking at. Sometimes you're looking at cost effectiveness, which is different, because you may then create more benefit at a higher cost, but because the benefit increase outweighs the increase in cost, it still makes sense. That kind of formula or formulation may not work in resource-scarce countries. In Singapore, where we are relatively a bit more well off in terms of the resourcing, although there are our challenges as well, the conversation around cost effectiveness will work, but in some places I recognize that actually you have to outright talk about cost savings. Therefore, the approach may be a bit different. Thank you.
Thanks for the question, and thanks for the enlightening answer. I think it's been really great to hear about how the government thinks about evaluating solutions. For those of you that are building solutions that sell B2G or B2G2C, I think it's very important to look at what is the regulatory framework and what is the proof or the burden of proof that is needed. So thank you for sharing so much with that about us.
Thank you.
Just like to invite everyone to give another round of applause to Stowo before we go to our next speaker.
Thank you, everyone.
So, next up, I'd like to invite Robin Sutikno. She's the founder of GUE Ecosystem, and she's going to tell us a little bit more about digital health, transforming business models for a better Indonesia. Robin, please.
Hi everyone, my name is Robin. Thank you so much for the opportunity to speak today. So, as mentioned by Pak Satyaji earlier this morning, Indonesia is going through a transformation in terms of the digital health arena and also the atmosphere. And also, as Pak Sutowo just mentioned just now, right, regarding data, a lot of it requires infrastructure and also the connectivity of the different healthcare players within the ecosystem. So today I will share more about the ecosystem that we have built, what are the key learnings, and also what are the potentials for other startups that want to start their own company, and also by private companies as well. So first, I'll introduce a little bit about what we've been doing, and then I'll share some learnings. Afterwards, if there's time for questions, please feel free to ask them. So first of all, GUE ecosystem. So for those who are in Indonesia, you know the word GUE. GUE is a colloquial word to say aku atau saya, which is I, right? So GUE, we started in 2016. We are a digital health company where we built an ecosystem that connects mothers to doctors and also to pharmacies. So this is the impact that we have created in the last 9 years. First of all, we help 4 million moms nationwide in Indonesia. Then we work with over 100,000 healthcare providers. This includes doctors, specialists, medical students, residents, and also midwives. Then we also send more than 1 million packages every year. This is medical packages. So we work with pharmacies or apotek to send the medication directly to the customer or the patient. Then we also work with Faskas or healthcare facilities across Indonesia to connect them to Satu Sehat. So again, as Pak Setyaji mentioned today, when we want to create this landscape and also make sure that there's connectivity, it's very important to actually ensure that the healthcare providers, the healthcare facilities are actually connected and they have that infrastructure within each center. So today I'll start off with something about network effect. So this is actually an economic principle, right? When basically if we are in this one room, if there's only one person, then perhaps that person may not feel the benefit. It's the same thing if we go to a party or if we go to an app, mobile app, and there's very few users, then it's very difficult to derive benefit from being there. However, once we have multiple users in the same room, then we can have interaction, then we can ask each other questions or even have discussions. And hopefully we can garner more benefit from that interaction. However, oftentimes we think of these network effects as just being one type of user. So for instance, we think about being in a community, then it's the same, for instance, in Indonesia and Singapore, nowadays there's this new trend of tennis and paddle boarding. So a lot of people are playing pickleball, paddle ball. So once you have another player in the field, then you can start playing. If you have another 2 people, then you can start doing doubles, right, for instance. But usually we don't think about what happens if there's multiple types of users. So I'll go through first about what we've been doing, and these are our initiatives that are focused on each kind of user. So a lot of the times in Indonesia, a lot of the digital health startups focus on creating a super app. This was very, very popular since 2009, whereby one app can cover multiple platforms and multiple types of users. Whereas our strategy is actually to focus on one kind of user. So I'll start with Teman Bumil, our largest platform, which connects 4 million moms to one another. This starts during fertility phase or family planning phase, once they are pregnant, and once the child is 0 to 5 years old. So this app provides mothers, we started as an educational platform, so it's just the mothers getting information to us. Then we created an effect whereby we connect them to the healthcare workers, meaning doctors, pediatrician, OBGYN, and also midwife. Then we also connected even further to create an offline to online approach where we have screening programs. We work with kader or people working in the Puskesmas community health workers, so mothers can get access as well and get that information via the app. And most recently, we also created a community where over 200,000 moms are in our WhatsApp groups and also our forums. They can ask each other questions, provide mental health support to one another, peer support, and so on. Then we have the doctor platform. So a lot of the times we focus on doctors as merely a supplier when it comes to the digital health ecosystem. We think of the doctors as the people behind telemedicine, providing the consultation or providing MCs, as mentioned previously, right? But we rarely think about doctors as the user or as the person that we want to care about. So in the middle, we have doctor to doctor, which is our doctor-centric platform. We enable over 110,000 doctors out of 160,000 doctors in Indonesia to renew their license, to manage their license points, to get webinars, and this was particularly important during COVID. Then we also provide doctors with jobs while we connect them to our teleconsultation platform, which is DConsul, that is currently live in Tokopedia. And we also funnel the doctors to offline clinics. A few years ago, we worked together and acquired Assist, which is a clinic information system, currently the largest in Indonesia, because 11,000 clinics, 5,500 of them are currently using Assist, and this is already connected to Satu Sehat. So as mentioned, if we want to upload our EMR so that it can be analyzed, so we can get insight from it, or we can do forecasting based on these EMRs, then we have to ensure that the clinics actually have a laptop, have a system in place that where they can collect this information, log it in, and send it to Satu Sehat. So that is what Assist is currently doing. Then, once we find the patient with the doctor, usually we get a prescription. But in Indonesia, as mentioned regarding access, it's not always easy. So in 2009, when this first started, we first started, a lot of the pharmacies don't actually have a platform. And what we've done is we've created GPOS, which is a mini EMR system for the pharmacies. So if you realize the Satu Sehat program currently focuses more on clinics and hospitals. However, the next phase will be about pharmacies. How do we upload the data that is coming into the pharmacies, for instance, prescription medication, and upload it to Satu Sehat? So this is where GPOS comes in. This is a mini ERP system. About 2,000 pharmacies use it to manage their inventory, manage their purchasing. Then we also help with the purchasing of B2B, meaning we help with about 15,000 pharmacies. We help them buy directly from the wholesalers or from sub-distributors as well. And again, from this, then we can get data about the supply chain of pharmaceutical products, medical devices in Indonesia. Then, lastly, we have GoApotik. So in Indonesia, on average, the data is one person. If they have multiple items in their prescription, they have to go to about 5 pharmacies to fulfill their prescription, because not all pharmacies hold the stock. So what we have done is we've brought the pharmacy concept online. We work with 7,000 pharmacies and bring them on Shopee and Tokopedia and now TikTok, so then they can sell medication online, ranging from OTC medication to prescription medication. So again, from here, we get data about the purchase of medication, especially online, and even in big marketplaces. So currently, we have the largest market share in Tokopedia and also Shopee. So as you can see here, it's no longer a network effect between the same kind of users, but it's also how do we connect them to one another? How do we make sure that the mothers can get care from the right doctors? They can get the medication that they need for themselves, for instance, or they can get folic acid, for instance. So this is in a nutshell our ecosystem, and next I will share about the learnings. So what we have learned from this exercise from the last 10 years is that, number one, there is a need to be able to focus on the kind of users, but then also figure out what are the connecting dots. How can we create benefits between the type of users? Number two is also cross-learning. So a little bit of curhat, or curhat is like sort of a bit of sharing about our initial experience, is that when we first started GoApotik, it was quite challenging because it's a chicken and egg kind of game. We don't have the traffic, and yet we want to gather the pharmacies. So at the same time, we started Teman Bumil, which is much more straightforward. It is a platform. You get the users on board. In the first year, we aim to achieve 100,000 moms on our platform, but we achieved that in the first 3 months. So from there, we learn how do we actually get the users? How do we get them engaged? How do we retain them? And that kind of knowledge was very important for us to then scale GoApotik. Then lastly is how are we continuously being challenged to create this mutually symbiotic relationship between the patient and the doctor and also the pharmacists online, as well as bring them together when it comes to working with government, for instance, or with other types of funds. So I mentioned the topic of today's discussion because it's also related to the hackathon, and I understand that a lot of the participants online are learning how to create their own startups. So I'd like to share more about business models. So as mentioned before, in general, when we learn from Gojek or Tokopedia, we know that convenience, you can also charge this based on pay-per-use kind of model. So this is done, for instance, in GoApotik, where the patient will then purchase the medication online. We can get paid per service, or we can get a commission. Number two is a shared economy, where we work with the clinics and also with the pharmacies to get them the patients, right? Because not all pharmacies and clinics are able to do their own marketing. So then we do a revenue sharing model and also a subscription model. And then lastly, we do O2O approach, or offline to online approach, where we can grow the existing businesses that we work with different cost structure. So for instance, we also work with the pharmacies that we work with, the clinics that we work with. They usually start with only 1 or 2 branches. But after working with us 1 to 2 years, usually they will then expand. So we have pharmacy networks that have worked with us from 1 branch to up to 10 branches. The same with clinics. And it's a matter of how do we scale with them, because their challenges is very different. If you're running one clinic versus you run 5 clinics, there's central purchasing, for instance, how do you manage your manpower and so on. So we also help them with that. Especially when everything is interconnected, then business model is very important, because the business flow can become much more complex, but then we can also derive more benefits for each kind of user. So for the future, and as we go into today's discussion, there will be much more talks today. There will be some from investment, for instance, some from AI. So a little bit about the future of digital health, which I think most of us are aware about, is number one, AI opportunities. But with AI, there's a few challenges. For instance, it's about the data that we derive. Where does it come from? Is this data, does it have to be relevant to that locality, for instance? Number two is the implementation. How do we bring this solution, AI solution, to the masses and to the right kind of user? How can we also train the user to use that AI model, for instance? So that challenge requires us to understand the user, be in that infrastructure, or be in the centers where these users are. So for instance, our network with clinics and pharmacies become very important for us to test. For instance, when we're working with AI scribes, right? So, or we're working with other smart forecasting capabilities, we need to be able to test them directly with the users. Second is prevention. When we want to do screening, as mentioned by Pak Setiaji and also by the Ministry of Health, we need multiple centers. We need also the manpower. So prevention, screening prevention, we have started doing this year in support of the Ministry of Health, because we believe that through prevention, then we can provide much more long-term support, and hopefully we can reduce the risk. And lastly is advocacy. So how do we work with the patient groups and also with the healthcare providers to ensure that they feel comfortable and they feel supported throughout the journey? We provide this through digital health, but again, we are in a way a partner for you guys to connect with the doctors and connect with the clinics and the pharmacies. But we are open to collaborating to see how we could then find synergies and provide more value to these kind of users. Thank you for today's discussion. Feel free if you have any questions.
Thank you, Robin. Why don't you stay on stage in case there's any questions? Any questions from the floor?
Thank you. It was very interesting presentation, but I want to ask just one technical questions about when you go with the Go Apothec to the e-commerce. You said that there's OTC and also prescribed medicine. So I was just thinking how you manage to, to sell the prescription medicine when it needs doctor's approval or the real prescription. Thanks.
This is a good question. So the Indonesian government has been very open and progressive when it comes to the sales of prescription medication online. So unlike other markets, Indonesia is unique in that sense, because Tokopedia, Shopee, or Shopee elsewhere in the world, they don't sell prescription medication online. So what we do is we work with government and also with the pharmacies and also the doctors. There are, in general, 2 flows, and if you'd like to discuss further about the change management and so on, we can discuss later. But the 2 flows are, number one, the patient usually comes, interestingly enough, they already come to the marketplace knowing what they want to buy. So usually this is chronic disease patients. First time they purchase at a hospital, they get price 100, for instance. But you don't know the price of in general, the price of the medication, right? But because it's chronic disease, you end up having to buy it every month. Then eventually you will look at how can I be more efficient? So then they will search online. Our model is because we work with Tokopedia, for instance, you can search the medication, you can find there might be some the same medication sold at 110 or at 80 rupiah, whatever. Then they can add to cart and then upload the prescription into their cart, and then this gets reviewed by the pharmacies. Once the pharmacy approve, then they confirm the order, then they send the order. That's number one. Number two, of course, we also have users that come into the platform not knowing, they only have a symptom, or they only have, I wonder what kind of I wonder what kind of medication do I need, right? So then they can do consultation within the platform. So this is available on Tokopedia, for instance. Then they can consult, get the prescription, they can check out. And then lastly is, in general, you already have a prescription, offline prescription, let's say like a paper. Then you take a picture of the paper and then you add to cart the items, upload the photo, and then you can check out. So there are different models, but again, to safeguard the model, make sure compliance, then we have to work with the doctors, we have to work with the pharmacies, and of course with government as well to ensure quality of care. Thank you.
Thank you. Any other questions from the floor?
So I'm actually curious with regard to AI and the use from a medication point of view. Like, how do you see that in Indonesia?
Okay, thanks for the question. So Dot does bot MD, right? So you're focused on AI as well. So for us, when it comes to medication, there's several points. We haven't touched, there is an opportunity, for instance, to verify the prescription at scale. But we haven't touched that because that's still part of the pharmacies are still able to do it within their capacity. What we're currently working on is, for instance, in GPOS. So GPOS is not only a mini ERP system, but it also works with the pharmacies to sell medication. So the pharmacies can, sorry. The pharmacies can buy the medication from distributors, for instance, right? So for us to do that, then we have multiple data points. We have offline sales data. We also have online sales data. We have search data. So then it's a matter of how do we then improve smart forecasting. So we work with some pharmacies. It's just in the pilot phase at the moment, but we're working with some pharmacies and also distributors to do that. But we're also looking at, does it require like an AI model, or is it more of a statistical kind of solution at the moment? Yeah, thanks for the question.
Thanks, Dot, and thanks, Robin. Amazing. So any other questions from the floor? Okay, in that case, thank you very much for sharing with us.
Thank you.
I think it's been really enlightening to see the consideration for regulation, the partnership with the government. As we all know, healthcare is not like some of the other more consumer spaces. It's very regulated. And that's one of the challenges that we want to bridge, right, through this hackathon and accelerator program that we run later in the year, right? It's helping those of you who want to do something big in this space to break into the space, right? So we've got all the speakers that you see today are among our mentor panel, and you'll get to engage them as part of the hackathon as well. Next, I would like to invite on stage Johan Sapanau. He's the head of health innovation at the Institute for Digital Medicine, also from NUS School of Medicine. Johan, please.
Good morning, or maybe good afternoon now, everyone. Thanks for being here. Thanks for the invitations also and putting this event together. Thanks to everyone online watching us now. So my name is Johan Sapanel, and I'm part of NUS. I'm part of the School of Medicine under Wisdom. So Wisdom is an institute for digital medicine. In short, what we do, we look at tech development. So we have in-house engineers. Most of the solutions are AI-based. So tech development, we look at the clinical validations within our cluster, NUH and UHS cluster. So west part of Singapore, in partnerships with our physicians and clinicians. And an important aspect of our institute is also about the implementations, right? The translational aspects of technologies. We have so many technologies out there but are not being used by anyone, right? So we are trying to address this gap between what we call the efficacy and the effectiveness of technologies, and for technologies to be used by our physicians, by our nurses, and by us at the end of the day as potential patients, right? So today in this next 20 minutes, what I would want to share with you is maybe two things. The first one is like we have many issues we could address with technologies, right? But I have only 20 minutes, so I've chosen to focus on one, which is what Sumoto mentioned earlier, which is basically our aging societies. We are all aging, unfortunately, as we speak. So I'm going to focus on this one. And in the second part of my talk, I would be a bit more tactical and share specific tools that might help you to ensure that you have the right problem that will deliver value to your stakeholders at the end of the day. So, first part about aging. I have a couple of good news, but I have also some bad news. So part of the good news is that we are all the lifespan. So the lifespan basically is increasing. And if you look at across countries, and for example in Singapore, between the 60s to now, over the last 60 years, basically on average, resident in Singapore, Singaporean could expect to live about 18 to 19 years more today versus in the 60s. So I guess that's very great news. In Indonesia, not about 18, but it's like 24 years more versus in the 60s. So that's the good side of the story. But at the same time, what you see on the top right of the slide there is the decreasing of in the fertility rate, and basically roughly by half over the same period, they decrease by half, right? And that's why you see these two curves crossing on the top right. Yes, we are living longer, but the fertility rate are also decreasing massively over the last couple of years, and this is an ongoing trend, right? And this is, again, not about Singapore or Indonesia, it's about what we see across countries. And so this is the not so good news, I guess. And so what we see is that aging is one of the most significant social transformation, not only socials, but through our economies, industries, societies, our families and communities. And the questions to all of us is like, are we ready to embrace the change? Are we prepared as a country, as an economy, as an individual also, right? About all these transformations. From a healthcare standpoint, think about all this like chronic disease and how earlier and earlier we are screening and diagnosing kids and adults with chronic disease that in the past would be a couple of years later, right? Think about the healthcare delivery, on the implications of such trend will have in terms of healthcare delivery, in terms of workforce size, and so on, right? So to deep dive a bit further, I want to share with you this demographic change that we have seen across countries. So we are looking at societies, classify societies between like aging societies, aging age or super age societies, right? So this is the percentage of 65 and above that you have in a given basically country, right? In France, it took them about 150 years, 145 if you want to be quite specific, to go to that transformations from an aging society to an age society to a super age societies. Guess how long it took to the US, in Southeast Asia and Japan to go to such change? Just, sorry, I don't have the animations on the slide. Is it, sorry, I can't. I guess you're not going to see. So basically, what you can't see now is that it took us, Japan, Southeast Asia, East Southeast Asia, and the United States, about 35 to 40 years to go to the same transformations. In Singapore, it's about 28 years. So if I put this, if I rephrase basically, or put this in a different way, basically, and in Indonesia is about 24. So Singapore is going to the same transformations in 24 years what France and some of the countries they did in over 100 years. So that's the speed at which basically our societies are evolving and changing. Now, when I look at the healthy longevity, and I guess you're not going to see some of the animations on the slide, but what is really important is like, yes, we are aging, and that's great. But again, we need to make this differentiation between aging, the lifespan, versus the health span, right? Health span is about the number of years that you are living disease-free, basically, without any kind of medical conditions, chronic disease, right? In Singapore, you can expect to have this healthy lifestyle without any chronic conditions all the way to 74. In Indonesia, it's about 62.5, right? But the gap that you see between health span and lifespan is about 11 years in Singapore, right? So at 64, you have maybe your first, on average, chronic conditions, and then you could live until 85. In Indonesia, it's about 9 years. The gap between the healthy longevity of a lifespan and health span is about 9 years. So we have 9 years here in Indonesia, and we have 11 years in Singapore. And what we have seen over the last couple of decades is that the lifespan tend to increase. That's the good news. But the health span is not increasing much, right? So we are living longer, but we are not healthier. We're not. So basically, you get still diagnosed with the first chronic condition at the same age, right? So when you think about innovations and technologies, we have to think also about not about increasing lifespan, or not only, but how do we increase the health span also for all of us, right? So, I can't even, I'm sorry, from bad to worse. So one of the implications, if you look in the context of Singapore, and as I kind of said in the questions earlier, is just about 5.5, 5.6 plus million inhabitants, right? But if you look at how much we are spending in healthcare to address that gap, right, is about a couple of billions that are basically spent, and that budget is like 5 to 6x in just about 20 years, right? So we are about to spend 45 billion basically in just a couple of years for 5.6 million inhabitants, right? Again, as I said, a budget which is like 5 to 6x. So how do we address that? Is this the efficient way of spending? It's not about just the spending, but is this an efficient way to spend, and how do we prevent basically individuals to go back to the hospitals? So if you're not convinced about why this is so important, I just want to share a couple of data points with you because you might already have seen and you know, yes, we are aging and so on, but how is this important economically speaking? And sometimes it's about, you know, the ROI. I mean, sometimes it's good to have a bit of like financial aspects in a healthcare kind of conversations. I want to start by the last point. I think logically you will see that it's maybe the most important point for all of us. So if we could delay the onset of your first chronic condition by just 1 year, right? So instead of having type 2 at 42, you get your type 2 at 43. Instead of having whatever hypertensions at like 61, you get the same conditions at 62. Just by 1 year, the cost in the US is about 37 trillion. I'm not talking about million or billion. And this is just 1 year, just basically increasing the health span by just 1 year. That's 37 trillion in the US, right? So now, let's move to the first point. Now that you know that you could potentially have 1 more year disease-free, maybe we could consider all of us walking a bit more. And if we expand or extend the walking life by 1 year, just 1 year, that's in a country like in the UK is 1.5% of GDP more over like 4 years, right? And the contributions of the 60 and above in the economy in like countries like in Europe or in the USA is about 7+ percent basically to the GDP. So this is why it's not important to us as individuals in terms of the day-to-day kind of experiences, healthcare systems, but the overall sustainability of our healthcare systems, right? So what are we doing now in the context of Singapore? I want to share a quick initiative which I think is really, really important and how we are addressing that trend and how we are looking this not from an issue or complexities, but has potential opportunities for all of us and for the systems. So if you recognize the map of Singapore at the back, that what you see here in the circle is what we call Queenstown. So Queenstown is a district in Singapore. It's about 100,000, 95 plus or 100,000 residents. And when we look at Queenstown as a district, what we see is that basically looking at the demographics of the residents in Queenstown, looking at housing, we see that Queenstown is basically Singapore in 2030. We already have basically 21% of our 65 and above in that district, right? So Queenstown today is Singapore in 2030. And so the questions for all of us being part of the West clusters and with our different partners is like, what could we do in Queenstown that we could replicate at the national level? What could we learn? How could we deliver care differently? It's about healthy aging, basically, right, in Queenstown. And so this is a partnership, so it's an initiative that is co-led by NUS, NUHS, and HDB, the Public Housing Authority. You see many more agencies, public, private. We are also working with a couple of like smaller, larger organizations part of this initiative. And at the end of the day, we have like 4 goals in how do we measure success. The first one is about healthy longevity, right? As I said, lifespan is important, but how do we increase the health span? Increasing healthy longevity, but also purposeful longevity, right? What are you going to do in your free time? How could you contribute back to the economy about volunteering and so on? Then it's about how do we promote intergenerational bonding and support basically all age group and create these communities. So one of the things, and I'm part of a tech workstream, so I'm a bit biased, so I'm going to share some of the technologies that we have considered. But basically, we are looking across the care continuum for all patients, for all residents, and how could we screen these individuals earlier? So we discussed earlier about dementia and chronic conditions, and how do we optimize the referral pathways, and how do we not have every single patient coming to like extremely specialized tertiary care hospitals, but how do we help and screen them in the communities with our nurses, our GPs, and then moving on to discharge of the patients, how do we improve also discharge of the patients? There is one technology, especially that you see the third one about ambient intelligence. This is a collaboration with Stanford University, and what we are trying there is to look at change in pattern in terms of markers. So we have a couple of sensors in your apartment, for example, and we look at any change in pattern that could predict a potential re-hospitalizations. So it's not about just, okay, you fall on the floor and then someone will come quickly, but it's like up to 2 weeks what we have seen, and we have a couple of publications out there online, but up to 2 weeks we could potentially prevent, if we have the right interventions, we could potentially prevent a resident, typically is about 60, 65 and above, to come back to basically to our hospital. So technologies is there, but how do we leverage also the technologies, right? So I'm also watching the time, so I want to move on to the second part of the presentations, which giving you a couple of tools to ensure that not only you're going to address a problem, but the right to ensure that you have the right problem and that is going to deliver value to stakeholders at the end of the day, right? So it's not about just having a problem statement. And before I moved to the academia, I was in the industries for many years, medtech, pharma, and what I've seen, and unfortunately what I see every day, still now in academic kind of settings, is what you see here. You know, we always say, you have to ask your customers what they want, listen to them, you have to engage with the patients, and that's great, that's the step one. But what you see quickly, and then you go back to your project leaders, and then, okay, this is my understanding of the needs of the patients or the end users, the physicians. Then you go back to the tech team, and the tech team, they have always solutions to address your issues or to design something new. And then as a consultant, this is how I will see these like fancy solutions, the top-notch solutions, right? To address the needs of our customers. Obviously, at some point you might want to charge, and this is maybe how is healthcare today. We tend to be charged quite high in certain contexts. Not much support typically for most of the solutions. And at the end of the day, you realize after spending some time, and I don't know how much from an investment standpoint, but you realize that there is a disconnect between what your patients, customers could be your physicians also, or nurses, what they expressed, what they shared, and what was really the solution that they wanted, right? And so this is really important to keep in mind because, I've seen for the last 20 years across public, private institutions, organizations, so just try to understand these different languages that these different individuals basically they speak, right? Once you understand where they are coming from, then you could really understand what's next and how to address understand their agenda. Okay, I don't have any animation, so I'm going to skip some of the slides, but just think that in any ecosystems, you have different stakeholders. As you have seen on that slide, try to think for each of them, your patients, right? So, but patients also the end user, the caregivers, patient advocacy groups. Think about the physician, not just the physicians, but the nurses, the caregivers, also allied health professionals, and how could you engage them and ensure that basically you could deliver the right value for them. And try to think about all of these different stakeholders, potential partners, and what is the value that you can deliver to each of them. As I said, you need to ensure that you have the right problem that will deliver value. And for us, I've seen many clinicians that would have the right clinical need, but it's not because you have identified a clinical need that could deliver value or could be scaled, right, in a country like Indonesia or like in Singapore. So you need to understand also, yes, we need to address a clinical need, looking at the inefficiencies that you have across the care continuum, but how you're going to deliver value to a specific individual and for each of the stakeholders of your ecosystems. And at the end of the day, it's like how you're going to make money. And I've seen so many entrepreneurs that look at the tech development kind of process as a sequential process, right? And when we develop the tech, then we move on to the clinical validations, and then later on at the end, it's like, okay, regulatory implementation kind of decisions, what is the business model? But I would really encourage you to think about this on day one, because there are some solutions that on day one we know are great, they are addressing a clinical need, but are not going to generate any value economically speaking for any of the stakeholders or investors that are engaged in these solutions. So try to challenge your thinking and your solutions by trying to think about how you're going going to address a need, a clinical need, how you're going to deliver value to each of the stakeholders of your ecosystem, and also how you're going to ensure trying to start thinking as early as possible about the economic or the monetizations of your solutions, right? And the right way of doing this, as I said, is engaging, is to being in the field, to talk to your different customers, the end users, again, your patients, your physicians, the nurses, have these conversations, but remember that what they're going to share with you might not be what they really need, right? And that's really the struggle that we have also. And we have, part of our research institute, we have a behavioral team that their expertise is really to try to engage and understand the perspective, the bias, and so on. But at the end of the day, we have to also interpret and filter and see how could we address from a tech standpoint, but how could we address or deliver solutions that will basically address their needs. And you might have seen this code, but I think it's really an important one as you think about in developing your solutions, that when you buy, like a quarter-inch drill, it's not really what you want, right? You don't want a quarter-inch hole. And I think all the solutions that we have, we're talking about AI and so on, that's great, but this is just the how to address a potential need or to deliver value to your customers, to your end user, again, the patients, and so on. So try to think for your solutions, what could be your quarter-inch drill and what could be, your quarter-inch hole for the solution that you have in mind that you are thinking, okay? And a good example is that is when you talk to two physicians or physicians and patients within the diabetes context. And a couple of years ago, I was speaking with a diabetologist or endos, and basically she said, for my patient, what I want is to reduce the glycemic variability. That's the physician ask. That's the physician need for, let's say, type 2 or type 1 diabetes patients, right? But when you ask the patients, they don't care much about this glycemic variability. That's maybe important. This is what the physicians would kind of communicate and share with them. But at the end of the day, if you ask them, they want maybe a bit more lifestyle and flexibility in their lifestyle, right? They want less constraints. They want less therapy efforts. So again, any conditions that you are going to focus on across the care continuum, think about how, for each of these stakeholders, what they want, what's their agenda, unmet needs, and how you could deliver value to each of them. I want to conclude on this one slide, and you're not going to see the bottom, unfortunately, due to the animations, but I would encourage you to read this use case that has been shared online, and it's from Google. So this was in 2018. And we are in the US, and Google, they came up with this new AI that could basically screen for diabetes retinopathy with 90% accuracy. So this was done in a US lab, amazing technology. And then what the team wanted is to deploy the algorithm in Thailand, right? Across 11 clinics in Thailand. And you see here on the top part of the slide, what is the standard of care today for patients in Thailand? You have to go to the different steps. I will not go to the details, but roughly, if you want to be screened for diabetes retinopathy, it takes like 2 to 10 weeks. This was the standard of care. And Google, through their algorithm, with a new standard of care, from 2 to basically 10 weeks, you can go down to 10 minutes, right? So on paper, and this is like, as if you're an entrepreneur or innovator, you look at this, is like, this is amazing, right? I could kind of shorten, from an efficiency standpoint, the experience of the patient is going to be amazing. But Google, through the deployment of the solutions, they made a couple of assumptions, a couple of hypotheses, and most of them basically did not turn true. Like no stable Wi-Fi connections, they assume that basically the care delivered across these 11 clinics were more or less constant, where basically it was not. Each of the clinics, they had slightly different protocols on how they would manage the patients. They also thought that the nurses would be super excited about these new technologies that will come to them. Then they realized later on that basically the nurses were not too keen, because today nurses were involved in the delivery, in the screening of the patients, where now they basically were not involved anymore. The tech will do more or less everything for them. So the nurses were not empowered. So you have, at the bottom of the slide, you have the publications. I highly encourage you to read that, the sharings and the learnings from Google on that, on how coming from solutions in the US and how they failed to basically implement the solution, which was great on paper, but that did not deliver value because of a couple of assumptions that went wrong, basically. So as you're thinking about your solutions, and this would be my kind of last point on that slide, is that as you're thinking about your solutions, think about the problem statement, think about how you're going to deliver value to each of the stakeholders that you have in your ecosystems, but think also about what we call the deal killers. What are the couple of like 2 or 3 key assumptions that as you do your first pilot, let's say, that you are going to try to validate and you're going to try to test, basically? Because in Google, if you read the case, they had like 4 assumptions and 4 deal killers, and none of the 4 basically materialized and went true in the field. So try to think about problem statement and how you're going to deliver value. On that, it's my last point, but implementation is really important. The context matters, and we have seen this in the example of Google. And again, think about the ecosystems, and not just as your customers are just the end user, but there are a lot of different stakeholders that are involved in your ecosystems. And just to share a quick story, just last week I was with a physician in Singapore, and she developed a new solution, and she said one of the mistakes that she did is not to involve hospital administrators early on. So they went ahead, they did the clinical trial, they had all the evidence, and then like few months down the road, they went to the hospitals and hospitals administrators to look at, look, I have all the evidence, I have a great solutions, let's implement. And basically the answer was no, right? So now one of the learning after 18 months is to involve hospital administrators early on for her. And that's why I will invite you also to engage basically the different stakeholders as early as possible in your process, just to ensure that you have the right solutions, but looking at the kind of evidence that you will need to deliver value to these different stakeholders. If you want to know more, we also published a book recently, about a year ago, with John Hopkins, and we go through the process of what it takes to develop a solution to ensure that you have going to address a clinical need but deliver value, what it takes to validate, and especially when you have AI-based kind of technologies, like how do you basically run a clinical trial or perform a clinical trial, and about the implementations. On that, all the best in your pitching and proposals, and happy to answer any questions. Thank you.
Thank you, Johan, for that amazing talk. And sorry, big apologies for ruining all your punchlines.
No, it's fine.
So I'd like to open the floor to questions.
Okay, thank you for your nice presentation. Now I want to know how your institute run your clinical trial from many huge innovation in Singapore. Thank you.
So how do we run our clinical trials?
Yeah.
So, you know, we are kind of a small team. We have about 25 of us in terms of like the core of the team, and we have plus about 100 of indirect individuals involved. Most of the clinical trials that we have are either trials from existing solutions that we have in-house, developed in-house, and also from our clinicians coming from the hospitals, clinicians and physicians coming to us and say, I have these great solutions, could you help me develop the solutions, could you help me validate the solution? So for us, working early with clinicians and physicians is really, really important, because we have a few engineers and we don't want to come up with the next fancy tech solutions that is not going to address or deliver value to any of the stakeholders. So most of our trials are clinicians, physician driven, and I think this is important. Also what we do quite early on, before we move to a more traditional clinical trial, you know, RCTs and so on, we conduct what we call feasibility studies or usability studies, and that's why we have a behavioral team involved, because again, it's not because you have the right clinical evidence that your solutions, whatever safety and efficacy, will be superior to whatever is the standard of care, but we need to ensure that the solutions is going to be used by someone at the end of the day. And we have seen in one of the solutions, for example, that some of the residents that we have in Singapore did not have Wi-Fi, right? So this is sometimes in certain populations, certain groups, you have basics or assumptions that you would tend to assume that they have Wi-Fi, they would want a solution. So I would highly encourage you to go to such usability, feasibility study. before having a trial. And again, the way we look at clinical trials, like the typical phase 1, phase 2, smaller one and bigger one, basically. Thank you.
Amazing. Any other questions? So I really like that idea of supporting, people who bring solutions to you with not just clinical trials but usability trials. I think that's really, really important and maybe something underlooked or overlooked. Definitely going forward, if you've got a solution and you're building a solution and you need to think about usability studies, do reach out to Johan and his team. With that, thank you very much.
Thank you.
Okay. Next up, I'd like to invite Dorothea Ko, CEO and co-founder of BotMD, also fondly known as Office Dot. She's going to share with us a little bit about designing AI products to delight doctors and patients. I know that your solution is pretty delightful because my wife uses it all the time in the hospital. She's a doctor and she loves it. So let me get you the clicker.
All right, thanks. Do you have a clicker? All right, so you can hear that I have a little bit of a cold, so I'm actually going to try not to talk so much, maybe show a little bit more videos, but talk specifically actually not so much about BotMD, but actually the journey that we've been on. So started the company about 5 years ago, and the goal of the company has always been about building products to actually empower doctors. All right, so we want to figure out how to build tech that doctors actually like. Because usually when you introduce tech within the healthcare environment, right, people don't want it. All right, so that's really the goal of what we actually created. So the way in which BotMD works is actually we use AI, but we actually power chat apps to help automate workflows. Right? So the reason why we actually do this is that we realize that the majority of what you use within the hospital environment typically is very siloed. Right? So you got the EMR, scheduling, right, call center, none of it talks. Right? So what we want to do is that we actually want to make sure that you can use what you're already using, integrate it, but then actually power chat apps to make it very easy to reach the people that you need help. All right, so in Indonesia, somebody said it over at the other side, everybody's on WhatsApp. Right? In the Philippines, everybody's on Viber, Facebook, right? Thailand, Line. So when we actually power chat apps, we actually broaden your reach. Right? They don't have to download another app. Right? Part 2 would be that we can actually integrate everything you're already using. So it doesn't matter what EMR you're using, doesn't matter what chat app you're using, doesn't matter what live agent you're using, we will actually integrate it and we'll actually help you to automate. Okay, so today we actually work with the majority of public-private groups, mainly within Southeast Asia, Singapore, Indonesia, Philippines, Malaysia, starting Thailand probably later in the year. But before I actually talk a little bit about why we do why we do what we do, I wanted to cover a little bit about the journey of BotMD. All right, so people go like, why did you start BotMD? And actually, many people don't know this, but BotMD actually started in Indonesia. So here on the left is actually a doctor in the middle of Solo, Indonesia. All right, so she's a GP. Now, did you notice that there's no computer, right, on the desk? Right, so you actually go there, like literally all she has is a table, right, and then the doctor and the patient. Right, so usually when I meet these kinds of doctors, I go, what do you do when you don't know what to do? Because most of the time when we go and see a doctor, we assume the doctor actually knows. But let's say you're a doctor like this, right, 2 years out of medical school, right, what do you do when you actually don't know what to do? So when I actually asked that question, she whipped out the phone. Right, so this is probably like 6 years ago. So she started showing me like all the apps that she's using, right? But the app that she actually uses every day, multiple times a day, anybody can guess? Which app? Right, so doctors use WhatsApp, right? So she told me like typically when I don't know what to do, right, I actually take a photo, send it in the WhatsApp group chat, hope that somebody senior will actually be able to see what's going on and help me, right? So that actually sparked an interesting idea, right? And right around the time, There's a company called IBM. I'm sure you know IBM. So IBM actually came out with this thing called Watson Health, right? And for me, actually, the thing that I wanted to do is to actually build an AI that could pretty much instantly reply to any doctor question, right? So how do you actually do that? How do you take what is widely only a US thing, but actually make it widely available? Right? So at the time, I knew that given that many of them don't have like laptops, right, I had to deliver it on phones, right? And again, no better than chat apps, right? So prototype that I actually built when I was prior to starting BotMD actually was a Facebook bot, right? But they didn't know that actually the bot was me. Right? So I actually was pretending to be the bot. So I actually found like these 5 random doctors online. And I told them that actually the way in which they can try out software would go on Facebook, add it as a friend, right, and then query it. Right, so you can actually see this is the chat transcript from one of the doctors that actually used BotMD, which is actually Dot. Right, so the first thing he actually says is diagnosed as LE. Right, so when he actually said that, what I did is I took his query, copy and pasted it into Google. Then I went to Medscape, and then I copy and pasted the answer from Medscape back into chat. Right, so this went on over and over again. So at the end of the experiment, right, I said, what do you think? And the doctor said, this is amazing. I said, really, why? He said, oh, because it's fast. Right, it actually knows everything. Right, it's not like Google where you have to click links. Right, so it actually got me thinking, maybe I can actually build it out. Right, so what we ended up then doing is to actually start BotMD. Started BotMD actually out of a garage, like all startups. Right, so this is my co-founder, our intern car. Right, so we never parked the car in the garage. We actually parked it outside the garage, and we worked in the garage. But we grew from there. Right, so the journey that we've been on, it's actually what we call startup roller coaster. Right, up and down. Right, because typically, I mean, Robin knows this. Typically, when you start a startup, you don't really know what you don't know. Right, the only way to know is actually if you're going through the journey, you learn as you go. Right, so you go through what we call the depth valley. Right, when you're wandering around, you don't know what you're building. Right, every day is very depressing. Right, and everybody hopes to actually get up there. Right, so we've done this for about 5 years. When we came back to Singapore in 2020, right, COVID hit. Right, so when COVID actually hit, as you can imagine, it's like a huge problem everywhere. Right, so back then, the doctors actually came to me and said, can you help to build an app? Right, so I said, what do you mean? He said, well, we've got thousands of these people in dorms, right, who are COVID positive. We need to be able to monitor them, right? But we have like 10 doctors, right? So how do you have 10 doctors actually monitoring 1,000 people without going crazy, right? So it's like, can you build an app? I said, I'm not going to build you an app. Because as somebody who actually built an app, it's so hard to get anybody to download, open, right, use it, remember to come back in, remember their password, right? So I said, I'm not going to do that. Right, so they said, okay, well, what do you need? Right, so it's like, number one, you need to be able to do language, right? Because in the dorm, they speak Mandarin, Malay, Hindi, Tamil, Bangla, right? 2, it's be very easy to use. Why? Because you have 10 doctors, right? So 10 doctors cannot teach 1,000 people how to use it, right? 3 is that we only have 10 doctors, so you cannot overwhelm the doctor, right? The doctor cannot use the technology and be like, oh no, it's making more work for me rather than actually helping. Right, so what we ended up building was the very early version of BotMD. Right, so you can actually see this in Bangla. Right, so we actually delivered it in languages. Now the interesting thing is they actually took the prototype that we built and they went to the dorms. Then the doctors came back, said, Dot, they cannot use it. I said, what do you mean? I said, well, the majority of them actually are illiterate, cannot read. Right, which is a very big problem because you're delivering everything in chat. The predominant assumption is they can read, right? They cannot read, right? So we actually iterate it over and over again to the point in which we actually learn how to use like links, right, buttons, right, to actually build it out. Right. So when COVID ended, one of the NUH doctors actually came back. She said to me, "Hey, you built this thing during COVID. It's actually very useful, right? Can I use it for something else?" I said, what do you want to use it for? She actually came to my office, she gave me a PowerPoint presentation. She said, let me show you how my patients report their BP and BG today. Right? So if you're a doctor, this is very common. People take a photo, they write it out, right? Then they send it to you on WhatsApp, right? Then the poor nurse has to go and read the photo, transcribe it to the EMR, and titrate your meds, right? So we actually ended up taking what we had built for COVID, and then we modified it, right? So let me show you a video of how it works for NUH. Can you play the video? Thanks.
Welcome to Singapore, a tiny island city-state in Southeast Asia with over 5 million people living across a densely populated island. Today, Singapore is home to a rapidly aging population with an increasing number of acute and chronic conditions. To meet the growing demand for healthcare and manage hospital bed capacity, the National University Healthcare System launched a virtual ward program that allows stable patients to be discharged earlier into their homes. These patients usually require active vital signs monitoring by their clinical care team. This is why NUHS has partnered with BotMD to launch BotMD Care, the first AI-powered patient monitoring platform that connects doctors and nurses to their patients through popular chat platforms like WhatsApp. With BotMD Care, NUHS doctors and nurses can remotely monitor their patients at home without the patient needing to download another app. Here's how the platform works. Step 1. NUHS doctors and nurses enroll their patients using the BotMD Care dashboard. Step 2. Patients receive an instant message on WhatsApp with instructions on how to report their health status. Step 3. Patients can submit their vital signs, symptoms, clinical values, and even photos through secure forms sent to them in chat. If a patient forgets to report their readings, the AI sends them automated reminders all through WhatsApp. The AI can also triage patient submissions to alert clinical users when their patients need help, so that they can intervene more quickly. With BotMD Care, NUHS doctors and nurses have been able to monitor over 1,000 patients in their virtual ward, saving more than 3,500 bed days, helping NUHS scale high-quality virtual care to thousands of patients across Singapore. We are BotMD, your AI clinical assistant.
Can you go next slide? So we actually have, I think, since touched about 3,000 people from COVID times until now. But the funny thing is, so then I took what we had created for Singapore in NUH and I went to Indonesia. And then the Indonesians laughed at me. I said, let me show you what we're doing in Singapore. Do you think you could use it? And they said, why would we do that? Right? Because our volumes are super high. We do not actually have like a team that can remotely monitor patients like all the time. But it said, you know, we actually really like the WhatsApp thing, right? Because in Indonesia, everybody is actually using WhatsApp. Could you actually think about finding ways to help automate stuff that we care about, right? And so from a single use case, which was actually COVID vital signs monitoring to chronic disease, started to actually expand it out to a really wide range of clinical workflows, and again, through popular chat apps, right? So just to give you a couple of examples, so we started working with Parkway actually in 2020. For Parkway, it was mainly about digitizing radiology ordering, right? So, like, today, typically the doctor writes it on paper, gives it to somebody, then the patient has to actually carry that, right? So what we can actually do with WhatsApp is that we can actually entirely book the appointment start to finish, right? Send the reminders, send the forms, right? Totally through chat, right? Similarly with Mandaya, I think Dr. Ben's around. So with Mandaya, actually what we're doing together with them is to actually help automate surveys and follow-ups. Right, so about 3 days when you actually get discharged, the bot will go, how are you feeling? Right, so if you're feeling good, we go fill a survey. Right, if you're feeling bad, we say, do you want us to hand you to a nurse? Right, now that flow is completely automated so that its team can actually handle the volume. Right, similarly with Siloam, we've actually done quite a number of automated reminders. And the great thing about chat platforms would be the uptake would be high. Right, so that's something that we've actually learned. Right, so right now what we do is that we actually help to automate and digitize your entire care journey, right? From scheduling of appointments to, you know, remote monitoring, handling patient inbound, right, outbound, right, prompts, right? So you can actually do all of these things with BotMD and mainly through chat apps. Okay, so one thing that's very unique about BotMD is that because we've learned from doctors, right? So when you actually build a product for doctors, you know how conservative they are, right? It's like, I mean, there's enough doctors in the room. It's true, okay? So the doctors are very conservative means what? Right? It means that you don't actually want the AI to generate, right, too much. Because if an AI generates, what it means to say is the doctor has to review every single reply. Which doctor has time to do that? Right? So what we have an ability to do is that we actually have an ability to train it on any content that you feed, but it actually retains the integrity of what content you give. Right? So unlike Meta AI, ChatGPT, we will not generate reply. Right? Part two is that we actually know that we can actually have people querying in like English, Mandarin, Malay, Indonesian. Right? So the bot can actually help to auto-translate. Similarly, we can actually hand it over to a live agent needed. Right? Part two is to actually help automate follow-on. Right? So automating follow-on is simple. How do you actually help nudge somebody? Right? So if you think about it, today in the EMR, nobody actually follows up if they don't show up. Right? So say you booked an appointment and didn't show up, who actually goes says, you know, have you come back? Have you scheduled again? Right? So we can actually do this. We can automate pretty much any reminder, right, with the chat, track whether or not they click, right, direct them to submit forms if needed. Right? And then third will be scheduling, so you can actually power it end to end. And again, chat apps using your own EMR. All right, so just a couple more examples. Yeah, one other very big one that we're doing at the moment, prompts, right? So you can actually use BotMD to automate prompt delivery, send it out at longitudinal time points, right? 4 weeks post-surgery, 8 weeks, right? And the bot collects the data, triages it, charts it, and then you can actually view the aggregate analytics for everybody. Yeah. Right, so all the data we actually aggregate it within a lightweight CRM sits on top of your EMR. Okay, so for me, actually, if I come back again to building delightful products, right? Like, delightful products need to feel good, need to feel intelligent, right? The reason why most people hate bots is because bots are dumb, right? And nobody likes to go back and forth with a bot. So how do you actually build a bot that's not only quick, but has the ability to actually sound human-like, right? And how do you actually provide on-demand support for your entire user base wherever they are? So that's really what we're trying to do. All right, so part two is that we've actually developed our own technology, right? We actually have an ability to retrieve rather than generate, right? Meaning that you can actually have zero hallucination, right? So whatever templates you feed it, we will actually find template, right? You don't have to worry about a generative bot. Yeah. Okay, so for fun, right, I actually built a demo for BIMC Kuta, right? It's a local Balinese clinic hospital. So what I actually did is I fed the AI about 20 to 30 FAQs using their website on the left. Right, so it's just Q&A. All the content that we actually fed it was actually in English. So I'm going to show you a short video, 2-minute video, what it now looks like. Sorry, can you play my video now? Yeah. Yeah, thank you. Yeah, so you can actually see, we can actually query it. So the content is fed in English, right? But you can actually query it in any language and the bot will reply in the native language of the query. Yeah, right. Similarly, you can actually talk to it like a human. Where I need a visa, how do I do it? Right. So we've actually, so and again, you have an ability to actually do this with the content and you feed it. So the hospital or the clinic actually owns it entirely. Yeah. Right, so we're like, do you accept walk-ins? I need an appointment. Right, this is because they get a lot of tourists coming in from Russia. So I actually fed it some query in Russian. Now you can see that the variance is 0, right? So in other words, it doesn't matter if you query in English or you query in Russian, right? The bot will reply exactly the same way. Yeah. Right. Similarly, you can do like price, right, direction. So it can handle sort of like clinical and non-clinical queries all in one, right? So you can actually feed it whatever you need. Oh, yeah, so they actually have me test this out. I want to complain about a doctor. Okay, so here actually you can see the AI has actually got an ability to empathize with the user. It's not like you say, I apologize that you had a negative experience. Right? So it actually sounds a lot more human than a human would. And again, in whichever language you actually query it in. Yeah. All right, so I think that's pretty much it. Okay, so that's the final point. Happy to take any feedback or questions.
Thanks, Dot. Amazing. So, any questions from the floor?
Hello, I'm Andrian from East Ventures, I guess. Since you've started pre-COVID, and back then I remember there was no LLMs and all of these things, right? How do you see it, the release of the newest and greatest LLMs that we see in the past couple of years? How does it impact your product and business?
So it still comes back to what I said originally. Healthcare is a very conservative environment, right? I mean, I give you a good analogy to it. There was a LLM chatbot on Air Canada's website. I don't know if anybody saw that article. So some random person went on, like, said, I need to buy a ticket, right? So what do I buy in these dates times? So the LLM actually generated a ticket to buy, right? Then later the user actually bought the ticket, but needed a cancelled flight, right? But then because they bought the wrong ticket, right, Air Canada refused to give a refund. Right, so the user actually screenshot the bot and said, but cannot be because your thing told me, right, that I should be buying this thing. Right, so I kind of said, but this is a Gen AI bot, this has nothing to do with us. Okay, imagine if this happens in healthcare. Okay, so let's just take a non-scary example. Let's say you go and ask the bot, how much does the ECU package cost? Right? And the bot just randomly comes up with something on its own. Because, I mean, if you guys have played enough with ChatGPT, right, ChatGPT sounds very confident when it says, but actually you go and look it up, right, you don't actually know if it's right or wrong. Right? So you don't have the time and the ability to go and review every single reply from the bot. There's no way, right? So how do you have guardrails, right, to be able to ensure the integrity of the content that the bot actually puts back out such that the doctor doesn't have to worry? So we've actually built, I mean, we started out as a healthcare-only company, right? So we've always held true to the fact that the doctor needs to trust what the bot says, right? When we actually started out, training our AI using doctors. So that's actually the most extreme form of training, right? Because you're getting a very educated user to actually review the bot. Even now, when we actually put out our consumer or patient-facing bots, right, we actually train it together with the help of doctors, right? So the model that BotMD has is very different from what a pure LLM would be, right? Because I don't believe in actually applying an LLM with zero risk. Yeah.
Any other questions? Or even just compliments?
Sorry, I did say that if you have a hospital and you want me to build you a demo, I'd be more than happy to do that. You can drop me a WhatsApp or you can send me an email. I can do it for you quite quick.
Hello, hi. Maybe this is a bit out of context, but since I'm a vet by profession, so can the same solution be provided for the...
Yes.
Thank you.
You're not the first vet to ask me that question. I met one at a party over like a couple of weeks ago, and yes, absolutely. Yeah, and you can be happy that it's been tested on humans before pets.
Hi, question over here. I'm Ridian, a doctor from the UK. When clinicians and hospitals have tried using WhatsApp in Britain, there's been a lot of pushback about data concerns. I was wondering how you navigate that, because the innovation seems amazing and so useful. Apologies, if that was at the start, I missed the first 5 minutes.
Okay, so let me go back here. Okay, so whether you like it or not, right, in Asia we live live on chat. Right? Sadly, okay, you're not from the US, but in the US they don't get it because they live life on apps. Right? So it's like, you go there, you tell them WhatsApp, they're like, what's WhatsApp? Right? But in Asia, we all live our lives on chat. So the way in which I think about it is simple. We actually control what we use a chat delivery channel for. Right? Because we have full control of it, meaning to say that you do not have to deliver sensitive patient data within chat. Arguably, some of the hospitals in that scene, right, they'll go like, so when you text a WhatsApp, you go like, I want to schedule an appointment, they go name, date of birth, gender. Okay, so these guys are already doing it, right, on their own. Now, with BotMD, we actually don't advocate for that. So we do not advocate collecting sensitive data within chat for 2 reasons. Number 1, collecting sensitive data and giving it to WhatsApp like that, no, don't do that, right? 2, when you actually do that, right, it's actually a very manual way of getting data in, right? Because then the human has to go and like copy and paste name, date of birth, right? So what we do instead is that we actually have our own version of a form where we can actually integrate into a form that the clinic or hospital provides, such that the data that's collected actually goes straight in, right? So then what do we use the chat channel for? We use it to remind, right? We actually use it to bridge, right? So if you've got your own app, we can actually bridge from the chat app into your app, right? Because we know that patients will open up WhatsApp every day, multiple times a day. They will never open, I'm sorry to say this, but they will never open up your hospital app multiple times a day. In fact, they'll probably delete it, right, when they don't need it. So the thing is that you have to use a channel that they are always on all the time. Yeah, be where they are.
Any others from the floor? Okay, if not, I just want to say thank you, Dot.
Sure.
It is really a breath of fresh air to have so much sympathy and empathy for the user. As a doctor, or as doctor or doctors, I'm sure all of us have had innovation pushed onto us from top down, and we all know how terrible that is. Anytime you put a free text field, you'll just get a full stop in it. I'm sure all of you have done that. It's really, really refreshing to see how such a user-centric thing has been built for patients and for doctors. We definitely want those kinds of solutions to be built out of this hackathon, right? So please take note. Please think of Dorothea if you need mentorship on that. So I'm now going to tell you about the slightly complicated lunch situation. Many of you are delegates of the Global Health Conference, so if you have that, if you have the lunch band, you go to Benjana and you use the lunch band for your lunch. If you are an NUS hackathon participant and you got one of those little paper vouchers for lunch, you can also go to Benjana and get your lunch there. They'll just collect your voucher, and yeah, so the original instructions to go down to the lounge bar, don't stand anymore, you can actually go to Benjana with the main. All right, so go enjoy your lunch. We'll see you in about an hour. Please come back. We've got lots of great stuff for you. Those online, we'll see you. Have a good lunch. Thanks everyone, hope you enjoyed your lunch. We're just waiting a few more minutes. We're pushing people back from the restaurant. Appreciate your time. All right, everyone, welcome back from lunch. Hopefully you all have had a good meal and are ready to hear about investing. So, we've talked in the morning about some of the healthcare and health system considerations, how to design a product that users will love. And now we're going to get a bit of investing outlook because, if you're building a product, eventually at some point you're going to need some investment and some funding. So please join me in welcoming Maria Marcia, investment professional from East Ventures. She's going to share with us about investing in healthcare equals investing in the future.
Hi everyone. So hopefully the event has been fruitful for you. Firstly, a couple of thanks to the NUS team for inviting us. It's an honor to be here, and I have to say the conference track so far has been insightful. Everyone gives a lot of really good advice. So my name is Maria. I'm an investment professional at East Ventures. In my previous life, I was a banker, and then I made the transition into the VC world in 2016. And I have spent the last 3 years with East Ventures. So East Ventures is a sector-agnostic venture capital firm where we have over 1.5 billion US dollars AUM. Spanning over the early stage until the growth stage. We have started our journey since 2009 and has since invested in more than 300 companies in Southeast Asia, met with a lot more than 500 founders, and enjoyed more than 45 exits. So people often ask us, what's our next move? And at East Ventures, we believe in these three next frontiers. One is AI first startup, second is climate tech, and third is health tech. So AI first startup, in the last, I think about 2 weeks ago, we hold an event in our office in Jakarta to talk about how DeepSeek is changing the AI landscape in Indonesia. And for climate tech, together with Kadin and World Research Institute, we have launched a free website where, as a corporate owner or SMEs, you can calculate your greenhouse emissions for free. And then we also have the CIIC Climate Tech Innovation Challenge together with the Temasek Foundation every March. And health tech. So we participated in COVID relief efforts during the pandemic, and we also have participated with the Indonesian Ministry of Health for an acceleration program for the past 2 years. And our focus into healthcare is also why I'm here today. So why healthcare, right? And let me rephrase and reiterate this question. What makes a venture capital interested in healthcare? So this is the things that the investors see. We observe this. We observe that there is a high prevalence of non-communicable disease and earlier cancers. So almost 15% of diabetes prevalence in Singaporean adults and about 10 million diabetes patients in Indonesia, and this is a low estimate because I think a lot of people go undiagnosed in Indonesia. And there is also the earlier cases of cancers, in particular colorectal and breast cancer. Another issue is the elderly population is also growing. So about 17% of Singaporeans are elderly, and in Indonesia it's still 6%, but it's growing at a very high rate of 4.8% for the next decade. Not to mention, right, in Southeast Asia, we also have the wonderful burden of the infectious tropical disease that is unfortunately not heavily researched by the more advanced healthcare countries like the US or the EU because it's not so profitable. And I'm Indonesian, and you know, from personal experience, it's even more saddening because we also have the highest tuberculosis prevalence in the world. So whenever we apply for a job, they will ask us for a TB scan just to make sure that we are all clear. And every time you go make a visa for a temporary stay outside of the country, you also have to provide the same. So in terms of the supply side, there's the global benchmark of the infrastructure, so 2.9 for hospital beds per 1,000 people. In this case, Indonesia is lagging. We only have 1.2 per 1,000 people, but Singapore supply is actually okay. And we also have, in Indonesia, we also have less physicians than what is commonly standard. And our R&D spend is only 0.2% of our GDP, which is compared to Singapore, it's quite behind. So what this means is we see the demand is rising, and we see that the Indonesian supply is lagging. So this means we have a lot of problems, but with problems we also have opportunity. So as a venture capital, the bigger the problem, the bigger the value, and thus the bigger potential returns for us. And then secondly, we believe that healthcare is an enabler, because without healthcare, all aspects of life basically collapse. Economic productivity drops, quality of life plummets, social structure will weaken, and we were just in the middle of it, right? During the COVID pandemic, particularly for the Delta wave in 2021, the situation in Indonesia was quite chaotic at the time. So, you know, if people are sick, how are they going to be productive? How are they going to innovate? And we did a research in 2020. In 2022, we calculated, right, that additional 5 years of productivity for Indonesians equals to additional $10 billion in GDP. So healthcare, we believe, is the foundation of society, and it is important that investors understand and believe this. Third reason is the healthcare sector is very resilient. The number of deals during the COVID time in 2019 to 2022 is quite stable compared to the previous years. So as a sector agnostic firm, investing in healthcare is our way to also manage our portfolio risk. So what are the key trends and opportunities that we see? Firstly, it's about digital health acceleration, leveraging AI. So leveraging AI means tackling the limited supply by increasing the capacity much faster with only a fraction of the cost. And this doesn't mean that we are looking to replace doctors with AI, because at the end of the day, someone needs to own and be accountable for the diagnosis. What AI can do is they can help alleviate the administrative burden for doctors. For example, taking the notes, accumulating relevant studies, recommending potential diagnosis. And for example, in our EV ecosystem, one of the winners of our healthcare accelerator with Indonesian Ministry of Health in 2023 is a company called NextMedis. They leverage AI as a clinical decision support for doctors. It recommends potential diagnosis. So NextMedis provides EMR for clinics and Class B, C, D hospitals, and they are driving the EMR adoption in Indonesia. They are also now foraying into AI imaging tech as well. Other opportunity idea for AI, because the cost has dropped so much because of DeepSeek, could be AI-powered pathology in Indonesia, because there's only 2,500 pathologists in Indonesia. They are also concentrated in more urban areas, so there's not enough pathologists, and they're not dispersed well enough for the Indonesian market. Secondly, is about remote patient monitoring. Why is this important? Is because it leads to more proactive and continuous care instead of the more reactive hospital visits. And as an example, we invested in Avice Health, they're doing asthma monitoring for COPD sufferers with a device about this coin size. So their thesis is not all of asthma attacks actually need emergency intervention. And that device is able to triage the attacks that need emergency and the attacks that don't. So it sends the episodes data for doctors for monitoring, and then it can help with the parents to actually not go into the emergency department for something that is actually a actually not emergency. And their device is already FDA approved. Second key trend that we are seeing is the solutions are becoming more preventative and personalized. So disease prediction, right? It can happen in two ways, I think. One is knowing about your genetic tendencies. So we invested in Nala Genetics, which have the product to test monogenic and polygenic risk score for breast cancer and cardiovascular health. What this means for patients is if you have a higher risk of breast cancer, you can go for more often mammography for the eventual diagnosis. And if you have higher risk of cardiovascular disease, you can get started on statins early to avoid having a bypass surgery in the, say, 20 years ahead. Secondly, for disease prediction, is also knowing where your current lifestyle actually will lead you down the road. So we invested in another portfolio called Mesh Bio. Say that you're a type 2 diabetes. There's a myriad of heightened disease risks with having this condition, right? One of them is chronic kidney disease, and Mesh Bio's product predicts the likelihood of these patients, of this type 2 diabetes patient, to develop a chronic kidney disease in the next 3 years. So This means you now have 3 years extra to make some changes into your life and avoid developing a chronic kidney disease. And secondly, it's about microbiome-based innovation. So we invested in Amili, which is the leader in this sector, because Southeast Asia has one of the highest rates of gut-related disorders. So personalized gut solutions can prevent obesity and also diabetes. The third opportunity that we have observed is the healthcare access gap. So this is an opportunity that we have observed because I haven't seen quite a lot of startups doing this, so this is a bit of a missing piece in our ecosystem. One of them is an innovative financing model because the out-of-pocket expenses is high in Southeast Asia. So I'm looking forward to meeting more founders who is doing this. Secondly, it's about infrastructure. So it's about supply chain and logistics access in Indonesia, because medicine shortages in rural areas is still quite common. And according to a study in 2016, about 5 to 25% of medicines in Indonesia, circulating in Indonesia, is actually fake because of lack of tracking. So we met with a couple. My colleague here is also one of the companies doing with the solutions. And we have invested in also in Supercool, which is doing the cold chain logistics to deliver medicines. And specific for Indonesia, right, there's an area of community-driven healthcare models because there are not many doctors, but we have a lot of nurses, we have a lot of posyandu, and we have a lot of what we call bidan. So in Indonesia, usually expecting mothers in rural area, they don't have access to OBGYN, so they would go to the nearest bidan and get their prenatal care there. So what are the opportunities here is the tech solutions for the frontline healthcare workers and also for their upskilling. So in conclusion, the key trends and opportunities that we see is the future of healthcare is digital, personalized, and inclusive. So I'd like to highlight a few of our ecosystem. We divided this slide into, so on the on the left side is more preventative solutions, and the right side is more diagnostics and curative. The above I separated into 2 parts, so Indonesian startups and Singaporean startups. So I have talked about Nala Genetics, Nextmedis. Nusantix is, we invested back in 2020. What they are doing now is they are creating HPV DNA test kits to prevent cervical cancer, because cervical cancer is one of the top cancer killers in Indonesia. So ladies, you can get this tested for Nusantix high accuracy HPV test kits from just urine sample instead of the cervical swab, and their product is available at Diagnose, Fillmore Pharma, and a lot of other clinics. PathGen is one of our Health Sprint Accelerator winners that we eventually invested, and they are doing colorectal cancer test to determine the subtype of the cancer for a more precise treatment. Relief and Intellect are our mental health platform. So Relief focuses on a more domestic solution, while Intellect focuses on more a regional and global play. Inspirasien, Health Pro, and Homage is our care platform. So Health Pro is a platform for nurses. So it connects nurses to hospitals, and it provides hospitals with a supply of nurses when there is a need, when there's a short-term need. And Inspiration connects patients with patient advocates to help patients who are not familiar with the healthcare processes. Homage is a home care platform based in Singapore. It connects patients with experienced healthcare workers for long-term elderly care. And if you'd like to get connected with any of these companies, I'm happy to connect you after this presentation. So having met all of these companies and observing all these trends, right, what are the lessons learned? So this is the lessons that we always push to our founders as well, and we always remind them of this, is first and foremost, we need to understand the market. So I really like the earlier sessions where a lot of the speakers are talking about, you need to get to know your market better, you need to know your customers, and I agree with that. I agree with that with all my heart. So, but maybe to add to on the market, right? Other than the customers, there are also the stakeholders. You also have to consider the country that you are operating in. So for example, in Indonesia, with the current political climate and the budget reprioritization, healthcare budget is also impacted. In Indonesia, we also have the culturally specific behavior, which, to be honest, a lot of non-Indonesian founders have said to me that they sometimes get a bit frustrated with Indonesians' seemingly more relaxed way of doing things. So what you need to do, well, I think you need to budget more time. Because the sales cycle in Indonesia is going to take a bit longer than what you are used to. So now that you understand deeply, you can craft your go-to-market strategy, and then you can execute. Execute is a key word because you need to execute something. It doesn't mean anything if you just plan but not execute. But you have to balance it with prudence and aggressiveness, right? And then lastly, you need to get lots and lots of feedback. Getting feedback from customers is key, because then you will be able to tweak your go-to-market, and you need to get your product market fit. I have personally rejected a lot of deals because the team over-engineered a product without ever asking the intended users if it is something that they need, and then they eventually go to market and nobody was willing to buy their product. So getting this feedback is really crucial. And also getting feedback from investors that you trust will also be useful, because as investors, we typically have a zoomed out view that may allow you to have additional perspective and also notice opportunities. And also please be careful of confirmation bias in this case. And this looks like a cycle because it is. So you don't need to have the perfect understanding of the market before you can execute. It's a all-fulfilling cycle. So as a closing thought, let us build the future of healthcare together. And I hope my talk here today has inspired some of you to start your entrepreneurial journey, and also satisfied your curiosity of how we at IsVentures think about our investments in healthcare, both now and in the future. Thank you.
Thanks so much, Maria. Now I'd like to open the floor to questions again. Does anyone have any questions about the investor's perspective?
Hello. You mentioned you're looking at some startups that were working on microbiome products. I was wondering what the business model for those companies tends to be.
Got it. So one of our startups that we invested is Amili, and they are the leading microbiome company in Southeast Asia. They're based in Singapore, and they are doing mainly three things. So they can be the expert researcher. So whenever a FMCG company wants to make a product, touting the use of microbiome, they can send the product to Amili and have them certify it to say, the expert in Southeast Asia is validating your claims. Secondly, they can also help the FMCG company to develop the microbiome product. And thirdly, they also do the FMT treatment, the fecal matter transplant treatment. Yeah.
Another question.
Maria, thank you for the insightful presentation. My question is, when you invest in digital health startups, what are the main criteria for you to make a positive decision?
So at East Ventures, we have two main funds, right? We have the seed fund and the growth fund. For the seed fund, we look mainly at the founder because sometimes the solution is so early that it might just be an idea first. So the founder is the most important. For the growth fund, we look at the founder, the business plan and how they were able to execute before, and also whether they are the market winner in that particular market they operate in. I hope that answers the question.
I'll ask a little follow-on to that. What do you look for in the founders?
So interestingly enough, I think a couple of weeks ago, our partner published an article about this. It's about entrepreneurs. So we look at the character. So how are they as a person? We look at their capability and their capacity as well. So character is how they are as a person. Mainly is their integrity. And then capability is their ability to learn. And capacity is their own inert talent that they have.
Yeah. Thank you. We'll just open to one last question. If not, we'll continue with the next session. Okay.
Thanks for your presentation. My name is Ian. I just want to ask, usually what's your time horizon for investments, for entry to exit?
Okay, so, and this is not just for East Ventures. So most venture capital firms, we have a 10-year fund life. So time from entry to exit varies between 5 to maybe 8 years.
Okay. Thank you very much, Maria.
Thank
Let's
you.
give her a round
Thank
of
you.
applause. So I hope you all have a better feel for the investment landscape, especially those of you that are really planning to found. These contacts in this context is going to be really useful for you in the future. Next, I would like to invite Evgeny Shvarov. He's from one of our key partners and main sponsor, InterSystems. He's going to tell you about the amazing technology that they have. Over to you.
Thank you very much. And clicker. It's working. Hi, everyone. Can you hear me well? Yeah. First of all, thank you very much for having me and my colleagues here from InterSystems. It's the first time we partner with HealthHack and supporting this great initiative for innovators. Yeah, a few words about myself. So my name is Evgeny Shvarov. It's a complicated Russian name, but easy to pronounce. Yeah, so I manage corporate venture fund in InterSystems and our digital health incubator. Yeah, and my topic today is hopefully a conversation, but I will try to add some topics. Yes, what are the tips on healthcare innovation? So because we are as a company involved in building healthcare IT for some time, and we invest in healthcare. And thanks to Maria, so as she explained before, that investing in healthcare is investing in the future, right? So I don't need to second this. Yeah, and so let's get it started. Yeah. So a few words about InterSystems Corporation. We are a software vendor, and we have a platform that is called InterSystems Iris that was considered for some reason, but we don't know why. Okay, we know, but happily it was considered as a platform of choice for electronic health record systems, and more than 100 were built so far and are in action. One of them is called InterSystems Track Care, that we also have AMR that's built on our platform, and including the largest in the world called Epic. So that gives us an option to say that we manage more than 1 billion patient records worldwide. Yeah, and we are presented in more than 100 countries, and here are some logos and companies hopefully familiar to you more that we are working with in Asia Pacific region. Yeah, speaking of how do we work with in innovation, yes, and how do we support this? In fact, we believe that, yeah, even we build software for healthcare IT, but it's important to invest in innovators, and I explain you our reasons for that. So, first of all, we support innovators on different stages. At the idea stage, where like hackathons like that, like Health Hack, where brave innovators come up with some ideas trying to solve very complicated problems in healthcare that, yeah, healthcare is, we have it working for like how many years, hundreds, but not all problems solved, right? So there is always problems that need a solution. So in hackathons is the place where hackers introduce first ideas, first approaches, how to solve yet another groundbreaking problem. And yeah, and we partner with the most important hackathons in the world, like Health Hack. And actually, by the way, right at this time, there is another hackathon that we are partnering with called Stanford, some university in the United States. Yes, and we provide our products that hackers can use to accelerate their solution for yet another problem in healthcare. And why we are doing this also? So it's, of course, it's great to have some given and participation innovation, but also for us it's a way to understand, are we still relevant? So we are gathering a fantastic feedback every time with every hackathon, because hackers, they just need to solve a problem in a very short time, and they need technology that helps them immediately. And this is what we hope our platform does, and we are gathering fantastic feedback from hackathons on idea stage. And sometimes hackers, they maybe have some solution, and they then decide to build a team and maybe have a startup. So sometimes startups appear not only from hackathons, mostly maybe not only from hackathons, but anyway, so a very early stage startup, they often need the support. That's why they go to accelerators, incubators, places where they can get some experience, support and experience, so have some option to prove their idea. And this is what this is a very important stage in building innovation worldwide, and it's great that we have a lot of there are a lot of famous and important accelerators and incubators in the world. So we decided to build to introduce our own, and 3 years ago we introduced incubator called Celestinus. I will share a few words more, so that hackers that start and follow with InterSystems have the logical next step, yeah, with their innovation. Yes, and also we help them to go to the market, and through this is why we also introduced InterSystems Corporate Venture Fund, and we help them not only with non-dilutive grants and equity investments. We also help with our ecosystem, which is worldwide, as you can imagine. Yeah, some details. So. And if you want to apply today for InterSystems Venture Fund or Incubator, you can go to startup.intersystems.co, where you can find ways to get more information on our venture fund and incubator and apply today. So this is information for startups, and can I ask the audience, are there any startups in the audience today? Could you please raise your hand? Yeah. Yeah, I would love to follow up further, but you can apply now. So what do we suggest today in our venture fund? We have non-dilutive grants of $25,000. It's just money you can get from us to build a pilot, a tiny pilot that will help you understand whether InterSystems technology, one of our products, fits your innovative idea, fits your business. So we hope it does, and if yes, so we also can invest in equity, and we usually start from $150,000, and we of course follow on in next rounds. Startup incubator. You can find it on celestinus.tech. Yeah, maybe complicated name, but it's definitely unique. Celestinus, why we named this our incubator with this way? Actually, Celestinus was a monk, a European one, who first introduced anesthesia in healthcare history. So, and we established it in Prague. So initially it's like offline incubator. Now it's online international incubator, which actually we are gathering our next batch right now. Yes, and so Celestinus, it unites. What's the purpose of Celestinus? Of course, we hope startups joining Celestinus incubator will get familiar with InterSystems technology more. So they will have an option to work with it, to get experience from our engineers, our managers, and we will have the access to InterSystems Cloud for several months on our behalf. Yes, and also we united with, we partnered with Novartis and AstraZeneca and Celestinus so that they can share their experience and introduce the problems they have in pharma, and maybe looking for solutions. And the last but not least, and maybe one of the most important things we hope startups, healthcare startups can solve with Celestinus incubation is, maybe it's not a secret, but it's very complicated for a newly born healthcare startup to get a first customer in a hospital. So I can maybe I can ask our audience, how many people working in hospitals here, and maybe related to innovation? Yeah. Yeah, and thank you. I appreciate you are here. So you can confirm that you do not usually invite startups to provide their super innovative solutions today, because maybe obvious reason is it safe? Who else already tried it and got some value, right? So anyway, in Celestinus, startups can have a first implementation of their innovation in a hospital. Today it's 5 hospitals that agreed to work directly with startups, and if there is a match in a need and in innovation that startups provide, startups can have a first reference pilot supported with intersystems technology. Yeah, and as I said, this incubator is quite diverse. We started in Europe, but currently the majority, it's quite international, and the majority of startups are from the United States, and we select them from this year from more than 90 startups applied, and we select about 20. Why the United States? Because in fact the market in healthcare IT is the largest in the United States. It's not a secret. It's today, but I don't know how it will be in the future, but this is the picture for today. Yeah, this is about incubation. This is supposed to be like suggestions for our hacking audience, but but I'm referring for the hackers who are watching this online now. So how to be successful in a hackathon. This is all makes sense. But I can tell you that according to like what I understand and see is the most working thing is when like MD, like myself now, comes to a scene and says, hey, I have this particular problem in my hospital and it's painful today. So please solve, make sure that what you're solving, the solution you are building is really something that GPs, MDs, doctors, they face in the hospitals today. So make sure that it is an actual problem. And communicate to them in introducing your innovations. So if what you provide as a solution can make sense and can make the difference. So I think this is the most important thing, and all the rest, like for the hackathon, of course it's like again speaking of the experience of the hackathon. So it's the best thing is to team up. Like to build your team and to test the possible. Usually on every hackathon you have partners that introduce their cutting-edge technologies. We do, at least. So in this hackathon we introduce our vector search AI and interoperability. Vector search AI. So it's our cutting edge. So please try. A hackathon is a way to try it, right? So and understand quickly if it works or doesn't. So I mean. Yeah, yeah, and of course have fun. So I mean, it's this is important in our life, right? Yeah, and but here I wanna share, wanna get back to the tips of and maybe lessons learned in healthcare innovation. And this is I will share like a few ideas. Maybe could be obvious for majority of people, but anyway, this is something that I strongly believe will work in building healthcare innovation. So if you are a startup, like referring to hackers that are working today in a hackathon, and actually I can share a story how we started Celestinus also. We had a hackathon, we supported the European Health Hackathon, and in the course of 84 hours, several teams, they used 3D printers, they used cloud technology, our technology, and in the course of in the end of 48 hours, they've built a solution that closed some urgent problems in a hospital of course, it's not like a certified solution, but it's something that already works, and there's some device even. And we thought, yeah, should we just give away? I mean, so that this team and this bright team and this it's like a first tree on a first leaf on a tree, like it just appeared, will disappear. So we decided how can we support this? And we decided to start Celestinus incubator so that these hackers can build a startup and continue their research, their moving from innovation to a product that can be used in a hospital in a regular manner. And that's how we started Celestinus. And fantastically, this team is called HTG Medical. One of their one of the teammates were even 17 years old when he participated in this hackathon. And last week they received their first investment round of $1 million. And they have, and it's after 2 years, and they have several pilots running. So with the solution, actually what they did, they introduced a device that helps to measure urine, like the weight, so that nurses shouldn't. With this, they shouldn't check it on time, but they will get an announcement when they need to to change this. Yeah, so automatically. And so this saves a lot of time and improves the healthcare for some European hospitals already. And this was introduced in this hackathon. So this is what like a story. Just to continue, I mean, okay, hackathon and solution is great, but what if you want to build an innovation that will bring value in healthcare and then be a real startup? First, the most important thing is you need to build a team. And in healthcare, unlike usual startups, in healthcare, we believe that you should have like the hustler and the hacker. Yeah, so someone who sells and someone who builds. Yes, but in healthcare, you need at least someone who understands healthcare, right? So just to make notice of that. So what else is important is build a team of advisors, because healthcare is one person is not enough. So it's so we have so much data, so much experience in this sphere. So don't hesitate, build this team early. Yes, the business model. The next important thing is, yeah, you might have built a fantastic product that is super valuable, and you can say it saves lives. But the reality is, if you're building a startup, you actually are building a business. So, and you will introduce your product and business not in a vacuum. You need to understand how business works in a particular region, and think about this a lot and try this until you understand until you see the traction, and until you understand that it is business working using your innovative solution. Yeah, and another important thing in healthcare is data and interoperability. Because whether you are building like a medical device or medical service or SaaS, you will inevitably face that you will create some patient data. It will be, maybe you will host it somehow, or okay, you build a device that measures something. You need to send this information somewhere. And this somewhere will be maybe some electronic health record system built on InterSystems or some other platform. Or it will be a lab, or insurance, or government. They will expect this data in some particular format. Sometimes very different of what you introduced in your solution. And the world is going crazy in this. Like if you want to host this, so some countries they introduce like standards, like in the United States it's HIPAA and GDPR in Europe and other standards. Then if you want to send this information, you will face such names as like Fire, HL7, CDX12, DICOM, whatever, and actually many of them. And pharma say, why should we follow digital health standards? No, we will have our own, like OMOP, I2B2, and more. So you will face this, and happily InterSystems can solve this for you completely. I mean, because we have products called Health Connect or InterSystems Iris for Health that already have these products that support all these digital health data formats for digital health and pharma, and can help you to transform one into another on the fly. Yeah, and of course you can build it if you have one client, one hospital, or like one pharma. You don't need interoperability with me. You can do it manually one time. But what if you have 10 hospitals or 50 hospitals with different data, different formats? You need help. Yeah, so this is important thing about healthcare innovation. Another necessary ingredient is in startups, especially, yeah, you will need luck because that's the reality. So it's, sometimes very famous entrepreneurs explaining their success, they say, sometimes I was lucky, yeah. But to get luck, we of course need to work hard before that, to achieve that. That was like must-haves and maybe some shortcuts that can make this journey shorter, yeah? Partnership and ecosystem. So it's hard to do it alone. And especially in healthcare, sometimes it is super crucial to get into ecosystem early. This will help you to get a feedback if what you do, is it feasible or not, at least. Yeah, please partner with vendors like us, because we will not only help you to solve some problems, but also we will help you with our ecosystem to maybe substitute your marketing department, I don't know. So like make your solution be famous like globally. Because what we do for example, in our incubator and venture fund, if we're working together, we are trying to bring startups into the most important healthcare conferences like HIMSS or Health in the United States. And we invite them to our InterSystems Global Summit and our regional summits. Yeah, so partner with vendors and don't do it alone. Participate in incubators and accelerators, because this is another shortcut for you to go fast in this long journey. As Maria said, it is like how many, 5-8 years, yeah? So maybe longer. Yeah, and conferences, of course. Another, it's like marketing, like this one. Yeah, so networking is so crucial. Like we know each other, we share ideas, feedback. I believe we all go home from this wonderful conference with new insights and experience. Very important. Another thing important in healthcare. Yeah, we have regulation. It's maybe a burden, and it lasts years and takes years to like approve some new medical device. There are different classifications. You need to invest and a lot. But yes, this is a rule of the game. So in order to help in healthcare, in human lives, we need to make sure that you bring only value but not harm, right? So check the regulation early, because for some businesses this could be an end stop, right? So like check it early if regulation will allow you to build a new healthcare innovation. And yeah, another important thing that may be connected to the first, like conferences and accelerator. So while you are building your healthcare innovation in a garage, make sure that what is your building is for doctors, for MDs, right? So show it to them through accelerators, incubators, maybe some innovation programs in hospitals. because in the end of the day, they will use it. And they can give, first they can give you a feedback that it's full crap and will not work, and this all makes sense. But on the contrary, if they love your product, they can be your champions and they can help you to get to the market and get some traction and start sales and build your shiny future as a business. And I forgot, and have fun, of course, because this is entrepreneurship is a long journey, like maybe 7 years at least from like your garage foundation to IPO and this shiny exit. Yeah, make sure you love it, love what you do, and have fun. And this is what I express to all the audience. Thank you. Maybe any questions? Forgot to say that, apologies. We supporting this wonderful hackathon, Health Hack, with GenAI technology that is can be implemented with InterSystems Iris Vector Search. This is our prizes. This is a URL for quick start. We also mentioned interoperability, and my colleague Merlin will express it later in her session. But yeah, so any questions?
Any questions from the floor? If not, I'll ask one.
Thank you very much.
Actually, let me ask you a quick one.
Sure.
It's actually something we talked about over dinner last night. Why is the interoperability engine so valuable to startups?
Yeah, the quick answer is you can build your startup in healthcare without interoperability. If you have only one customer, if you have more than one customer, you will inevitably have an interoperability problem facing to solve, and you can solve it with any vendors who support interoperability in healthcare. Because in healthcare, there's a zoo of data standards, and they are all important. It's not like some organization or association introduced a healthcare standard and it was useful 20 years ago and disappeared. No, it's still here, and maybe it will be here for 20 more years. Like, I don't know. To my knowledge, no healthcare standards disappeared yet. So there are still present, and there are still very big and important players you need to deal with and consider that use some ancient data protocol which was super shiny like 20, 30 years ago, but still important today. You need to talk this language. And you can talk this, but in healthcare you need to talk not only one language, but like 10 of them, 20 of them. It's like in human languages, right? So the more languages you talk, the more audience you have, and you can expand the business. But but in healthcare it's even crucial, because this is if you just need to follow standard, and you can implement it by yourself, but you can use industry-proven solutions like InterSystems one, InterSystems Health Connect Cloud or Iris for Health, that will help you to deal with maybe to set up a Fire server and to convert Fire to HL7 on the fly, or to support CDA and DICOM and whatever. Yeah, maybe if I answered the question.
Yeah, that's amazing. You know, I just wanted to bring it up because it's something that I faced. It's a problem that I faced in one of the startups I used to work at. So when I heard about it, I was like, why weren't we using that? Yeah. So thanks very much, Evgeny.
Thank you. Thank you very much.
Okay, thanks everyone. So our next speaker, Dr. Eric Daniel Tenda. I'd like to invite him on stage.
All right. Good day, everyone. So, first of all,
I would like to say thank you to Lowell and US for having me. I just actually arrived, that's why I look a bit naked. But again, it's always great to be back in Bali, even though it's not for holiday. Once I landed, I wish I'm wearing a short pants, right? And not a big hat, because this my mom will wear it, but wearing a hat, go to the beach, not to the conference. But again, let's give a round of big applause to the organizing committee for gathering everyone of us here. All right, shall I get my slides up? Sure. Okay, all right. We love technology, but sometimes technology fails us, right? So my name is Eric. I'm a medical doctor. I'm an internal medicine specialist. I'm a consultant in pulmonology and critical care, but I'm more specified to interventional pulmonology. Now I'm also building this new unit, which is Hospital Transformations Unit at Dr. Cipto Mangunkusumo National General Hospital. And also, it just so happened that I came across artificial intelligence, and I'm leading the AI at the Indonesian Medical Education and Research Institute, and a few others appointment. But last but not least, the Ministry of Health of the Republic of Indonesia, which is created under Pak Budi Gunadi Sadikin, the minister himself. So he actually made this working group, what we call POKJA, for AI in healthcare, and it's just launched about a month ago. So most of the initiatives for digital health and artificial intelligence will be brought together to discussions with this specific team. So I'm looking forward to see more startups, ventures, and of course future collaborations after my talk. All right, so I'll start my presentations with this. As a doctor, is anyone is a doctor here? I know my friend's doctor, another doctor, another doctor, doctor, okay. How many of you guys think that AI is a hype or a hope? Now, is it hype or a hope? I think it's a hype because I have a lot of PhD students back at Faculty of Medicine, University of Indonesia. So they came across me and asked me, Dr. Eric, if I want to do my PhD about AI, how long will it take? And how much will it cost? My simple answer is, when I did my PhD back in Imperial College London, it took 4 years to finish. And it took sweat and tears and a lot of money. Thank you for paying the taxes, everyone. I'm funded by the government, so that's why I'm back here now, right, Roel? So yeah. So I think there's so many misconceptions with people, especially doctors, because now everybody talking about AI. I will not say, please don't think AI is not easy. AI is actually very, very friendly, but you need to know how. Right? Okay. So my presentation is about 100 slides, so I'll be finished after probably 6 p.m. So bear with me. Breaks with coffee, right? So my first slide talking about how healthcare is actually not very open to innovations. I heard one of my the previous panelists talking about how difficult to actually penetrate healthcare with digital health and artificial intelligence, right? There's a lack of doctors shortages. You mentioned it, right? But again, if we look at the populations, yes, in terms of the ratio, we are lacking. But there's some called technologies that can actually help us to breach, or at least to make this gap even closer, right? Use the digital technology. Secondly, about lack of money, lack of funds. You mentioned about the fund as well. Lack of trust, right? We are the people who needs more confession. We need something more certain, right? Kalau nggak dilihat di depan mata, beneran, I'm so sorry. I'm sure Singaporean will understand this, right? If you cannot see in front of your eyes, you will not believe it, right? Even though you believe in God. But I mean, we are lacking of trust, especially in technologies. When people actually come to us with some of solutions, like what the partner just mentioned, we actually, I don't think this is good, right? But is that the problem? Or, again, we see more ventures, more startups come with this solution, that solution. One solution can actually probably predict 100 diseases, right? But more advanced the technologies, you get more divided environment, especially in healthcare, right? Okay. So, secondly, we are a bottleneck of adoption. If you see this, I'm a pulmonologist by training. So I use my hair quite a lot. I also work at private hospital. There comes my manager from my private hospital. So I will not work like this back in 1800 for multi-drug resistant tuberculosis. Definitely sure I will get TB after that, right? Second, look. Third, we use a stethoscope. And now, the present status of stethoscope, they use actually a digital stethoscope to even predict whether this patient's got pneumonia, or bronchitis, or severe exacerbations due to COPD, or asthma. See how actually time changed us in practice, especially for medical doctors, and also nurses as well, right? So is it us that actually the bottleneck of adoption? I'm going to leave it to you to answer, right? The third one, we are afraid of the unknown. So again, as a doctor, we always know this common terminology, or clinical evidence-based medicine is a must for a doctor. We need a good clinical practice. If not, I will not practice. If there is a good evidence, if there's a systematic review or meta-analysis, so on and so forth, then I'll believe it. That's a ground truth for the practice. But not until, have you ever, not lived, but do you know Garry Kasparov? Does anyone know Garry Kasparov? No, is it? No, you didn't watch too much TV, you watched too many K-drama, right? So Garry Kasparov is one of the first grandmaster in chess. That was back in 1990s. So the whole world will get shocked because Garry Kasparov was beat by the supercomputer, right? So can you help me play? Oh, sorry. Can you play this? Yes. Oh, failed. Oh, never mind. You can find it, but anyway, this video is actually very short. It shows that Garry Kasparov was actually beat by the supercomputer code named Blue by two steps. That's how the supercomputer actually, I would say, first introduced in more public space, right? Everyone was very amazed with the supercomputer. It can beat Garry Kasparov. And immediately, as a man, even a grown-up man, once they get loose, they call the mother first. That's what Garry Kasparov did that time, right? So this is a very funny video. So again, so why we need AI in medical field? Oh, Eric, do you have enough training? I do have enough training. I trained for 17 years in Indonesia and also in UK. But is it enough? No, definitely no. So these are the problems. So see, TB especially, Indonesia is still the second in the world with the most highest populations that got burdened with tuberculosis. And then the total number of TB cases is near almost 1 million, right? Not a good number, nothing to be proud of. All right, so these are the dashboard of Indonesian tuberculosis. But again, the burden of the disease actually should be, we should get a new program, not a new program, but we should get a solution by actually implementing digital health, by implementing AI, by knowing whether these patients could develop a tuberculosis or not based on their comorbidities. Why not we can predict things, right? So it brings to my next slide. If we incorporate all the things that I already mentioned in my previous slide, then I think we can agree that patients should be the center of care, right? As someone who also used to work for JCI, Joint Commission International, there's a special standard for this, patient-centered care, right? So again, I think this is the aim for us as a clinician, as healthcare workers, to see the future of digital health and AI. Again, I will not talk in details about this. I'm sure everyone here already very knowledgeable about AI, about digital health, but there's one dilemma. It's like Nelly and, is it Nelly and Kelly? That's the dilemma song. I'm trying to be funny, but anyway. But what I would like to mention is, people keep asking whether this AI will replace doctors. One of my first conferences, I would say no, but now probably I will say yes, especially for doctors who will not use or understand digital health and AI. They will be replaced by doctors who use digital health and AI. That's the future, definitely, right? I'll show you why. So we use this type of AI method. The first one is we use the supervised learning. Supervised learning means, let's say, if you have a boy with you, then you'll say, oh, this box you need to place with a square, this box needs a circle, this one is a triangle. So that's the supervised learning. You actually ask the person, or ask the boy as in the picture, to put things accordingly to what actually based on the place itself. And then, second, we have the unsupervised learning, reinforcement learning, and now there comes the deep learning. I attend one of the largest AI conference 2 weeks ago back in Bangkok, in Thailand. And then, 2 days before the conference, it just so happened that DeepSeek undertaking ChatGPT. Correct? Right? Yeah. Everyone was very amused with DeepSeek, especially when you use the deep thinking about R1, right? That's what they name it. But again, if you use so I tried to actually input my laboratory result. So when DeepSeek processed it with parsing, I would say DeepSeek is actually slightly better as compared to ChatGPT. But again, how we incorporate this into clinical practice, I think that's the most important thing that we need to answer, right? All right, so so what are the advantages of artificial intelligence? I know everyone knows this. Us as a human, especially me as a person, oh my God, I'm so knackered because I keep flying back and forth, India, Bangkok now, Bali, and then after that I'm going back to Bangkok again. So, as much as I travel, I cannot retain information. I can't even remember my name after 12 a.m. in the morning. I'm so sorry. It's not because that I'm ignorant, but because we are humans. We are a very limited species in the world, right? We are actually comes with a lot of burdens, a lot of things that we actually need to carry. Of course, family, boyfriend, girlfriend, and I don't know, loans, things like that. And also to work in medical field, it's not easy. So to remember your patient's details, let's say your name or your laboratory result or radiology, and then sometimes the patient's family will come to you with tons of or millions of questions like, Dr. Eric, how come this patient's got severe pneumonia? What's this bacteria will cause to the patient? Do you know the name of this bacteria? I don't remember the name. I'm so sorry. I wish I know. But with AI, if you get more information in order to get a clinical decision making, because us as a doctor, we also need the way of thinking. We also need a proper way to decide whether this treatment is suitable for the patients or not, based on the clinical evidence, right? So how can I retain much information if I get bombarded by invitations, bombarded by things that happen in the family? My family is okay though, to be honest. But, but again, I still need to deliver because our patients deserve to only the best, correct? So that's why we use artificial intelligence, where artificial intelligence actually can retain more information and become smarter over time, right? Next one, sorry. Machine is not susceptible to sleep deprivation. I am sleep deprived, look at my eyes. I think my eye bag can carry a lot of stuff in 1 month. If you want to grow groceries, just take my eye bag with you. All right, so it will not get to any problems with sleep deprived, right? And then again, it can get much more information, right? And then after that, you can also build these algorithms. Okay, 1 hour passed. So, clinical warning. right? So this is a way of thinking now. So we use clinical warning system or clinical decision making, which incorporates AI to actually look here. So AI, you get patient information, and then you get all these boxes here, which is actually probably part of, not probably, I'm sure it should be part of your clinical practice guidelines at your hospitals. And then after that, you will compare it with the current practice or the current clinical practice guidelines, which one is actually more suitable for your patients. Because every patient actually needs to have a personalized treatment. How many, I don't know how many pulmonologists here, but I'm sure everyone knows about COPD, right? Correct? So we usually give the patients LABA, LAMA, and ICS. But does everyone know that not all the patients actually can get LABA, LAMA, and ICS? So how can we generalize our patients without knowing their personal results, right? So this is why AI and digital health is a bit more superior compared to us. So how we incorporate this to our clinical decision making? So this is the top one is the classical way of thinking now. So us as a clinician, we give instructions to our residents, our fellows, or our nurses to say, oh, you should give this to this patient. I want you to give carbapenems for this patient, start norepinephrine for these patients with a target of MAP more than 65, right? I want to give ceftazidime, avibactam, because I want to get the lower procalcitonin level more than 80% as a target to control these infections. That's the way of thinking now. But if we incorporate AI, so clinician give instruction and put AI in between and see whether the results of incorporating AI is suitable to your patient, then it will decrease your subjectivity as a human. It will decrease it. And you will bring more your patient as the center of care. Because my treatment and Dr. Agun treatment probably different. We're probably treating the same patient, but the way we treat is probably different. You probably argue with me about how about the clinical practice guidelines in our hospital. Why can it be the same? It should be the same. But again, in terms of decision making, then incorporating AI definitely will decrease your subjectiveness, right? Okay. So this is how the artificial intelligence works. So I'm sure everyone knows this, right? So basically, if you, let's say, if you want to predict a plane, then you'll put a data set, two data set. First one is the plane. The second one is the non-plane data set, right? So you need to get a lot of this data, large data set. So if I can come back to my earlier questions to everyone, I shared about the questions from one of my PhD students saying that, how many data should I get? I was like, oh, as much as possible. I think that would be better, right? Because we need a large data set to actually distinguish which one is which one is birds, which one is bus with a background of clouds, right? Or which one actually a real plane, right? So we need a large data set here. And then what we need after that is actually the AI algorithm and build the learning process. If you see the slides here, it uses convolutional neural network in order to give us a better decision making and how we can predict better the outcomes. How can we better predict the outcomes? It should be the other way around. All right, and after that, you will incorporate the algorithm with new data, and then after that, we can get personalized medications for everyone, right? Easy. So this is how AI can be used in healthcare. You can actually incorporate data from medical images. I saw the previous presenter put .dicom, right? And then you can use laboratory results, basically everything. And again, I will not limit these slides to your understanding only for medical decision or medical, medical decision that you should make to the patients. But again, all this data can be incorporated to help your hospital management as well. How we should spend for pharmacy this year. Which one that we actually need to secure the supply chain for our hospital. you can use AI and big data. And now we're currently doing it at Ciptoon Kusuma Hospital. Oh, my time is up, is it? Oh, okay. Oh, God. Okay. Don't sabotage me. I'll be come down soon. Okay. Okay. Definitely not AI. All right. So I think I'm gonna continue. So yeah. So while waiting for my slides to come up, I still have 100 more slides after this. So any one of you who has experience, I mean, not experience, but any one of you who is a doctor, but also came across to AI in training. Oh, excellent. And you're from? Okay, and you also learn AI. Is it part of your master's training or PhD training? Master's training. Oh, excellent. When I was graduated from Imperial back in 2020, I was the first medical doctor who graduated with PhD with a background for AI. So I feel so alone that time. So it's good to see you. Yeah, you should join the group. Everything is okay? Okay. So can I ask you a question? So is there any AI software that you already developed or implemented? Okay. Oh, excellent. Have you met our friends here? Okay, yeah, you need to prepare your name card. I mean, it's a good thing. If so, it's already been. So it's not only for clinical use and for the sake of publications, right? So you actually now currently used it at your practice, or you're still developing it? All right, okay. So I think this is what happened to us as a doctors and researchers, right? Because we're doing these two jobs at the same time, most of our research actually end with publications, right? So that's why we need you, Marcia, right? To make things happen. That's right. I think the slides got scared of me, right? All right, so I actually want to share a bit of my first experience in developing AI. Yeah, I think shall we go to question and answer first before I continue, right? Okay. Any question and answer up to this moment? Anyone? No question? Quite confusing. Anyone? No? Anyone wants to collaborate with me? Yes, please, yes. Fire away while this chap's doing it. Yeah.
Okay. Yeah, thank you for the presentation. I'm just like curious, someone that's also.
Oh, yes.
Yes.
Never mind, fire away. Yeah.
Happen to be a clinician as well, but not a doctor. That's been using AI as well.
Yes.
And I'm just wondering, in your experience,
yes,
how do you measure the effectivity of the AI in terms of improving the quality of care or the productivity or anything that's affected by the AI itself?
By the AI, okay.
Thank
I haven't got your name though, to be honest.
Salma.
Salma, and you from?
From Penang.
From Penang?
Penang.
Oh, Penang.
Yes. It's
That's
an AI mental health. That's what I'm building.
in Indonesia?
In Indonesia.
Oh, you're Indonesian?
Yes.
Okay, all right. So I'll give you examples through my research, which I'm gonna get there in about 50 slides from now. All right. So again, let's go back again. So people actually, I'm quite happy to understand that one of the previous speaker mentioned about FHIRR and then HIPAA, because not many hospitals in Indonesia doing it, even none of it doing it. But again, as someone who actually worked, very familiar with JCI, and now they have their own sections about technology, healthcare technology. So I think one of the decree from our Minister of Health that is will play a very pivotal role in implementing electronic health records with HIPAA or GDPR standards, right? Thank God now we have some sort of like general data protection rules for GDPR, but I'm not sure if it's already implemented nationwide, but yeah, we're looking forward for it. But again, there's a lot of data actually we can get from our electronic medical records in terms of, again, we want to get all this data for clinical decision making, right? So this is the role of AI in medical record. I just want to share the few slides after this. This is actually the PubMed. So as someone with a pulmonology background, right? So we are actually the second last for studies in AI in medicine. The second last, the biggest one is pathology. But sadly, as mentioned by you, Marcia, right? Marcia, we only have about 2,000 pathologists, and not many pathologists are actually familiar with digital pathology. It's quite sad. The waiting time for someone who went to top referral hospital in Indonesia to get their immunohistochemistry results is about 5 to 7 working days. Well, me, working back in London 2016, I can get my IHG in between 3 days. But again, to understand whether, yeah, Eric, because you work in Indonesia. Actually, no. I talked to my friend from Malaysia. So for urgent ISC results, you can request for it, and they get paid, 5 minutes. Then they only got paid about 75 ringgit in Malaysia. You can decrease from 5 to 7 working days to 3 working days. But they only get paid for about 75 ringgit. I will not do it. But again, this is the disparities of AI research in medicine, right? So a quick one, this is a real case COPD. So we know Indonesia still have a lot of burdens of COPD, not only tuberculosis, as what mentioned, and also lung cancer, but I want to highlight it in patients with COPD because this is a reversible disease. And the nation healthcare expenditure is actually very, very big for our COPD patients because they need to get a maintenance treatment, right? So how can we actually predict whether these patients can actually benefit from the novel treatment, which is bronchial valve and bronchial coils? It's not ready yet in Indonesia. We're not using it now, currently. But back in London, what we actually trying to do, we actually want to carefully select patients with severe emphysema and COPD to get valve or coils. Why? Because all the patients, especially patients with severe COPD, they will not get better, no matter how many inhaler or puffers you gave it to them, right? So valve and coils are the last resort. There's another option, which is not offended, very slow. A thoracic surgeon will do VATS or lobectomy, right? But the complications rate is very high. So to carefully select patients using AI is important. We can actually predict which group of patients will benefit the most. And again, no offense to Lowell, who's a thoracic surgeon, or Gary is a thoracic surgeon, but bronchoscopically treatment, minimally invasive treatment, actually superior compared to the operative one, right? So together with my group of supervisors and I'm friends back in Imperial College London, so we developed this software. So the software is now widely used in the UK called LungSec, not only to select patients with COPD or severe COPD, but before the patient actually develop a COPD, now we know a term called pre-COPD. Pre-COPD can only be determined by using spirometry. But use this software before you guys can detect using classic spirometry with one single high resolution computed tomography or HRCT, you can predict whether this patient will get COPD or not, even before spirometry. And the best part is, with this software, we can actually measure the lung function at the lower level. How amazing is it? If we use spirometry, I cannot just measure, I want to measure just the right lung. Let's see if it's the right lung will improve or not. and block the left lung. No, it will not work that way. But using HRCT, just one single shot, HRCT, you can actually measure everything, right? So what is the outcome from this study? Yes, we actually, now the software is actually incorporated with other software, and it's already got the CE mark from European countries. So now it's widely used for patient selections in severe COPD to get valve and coils, right? I'm going to wrap up my presentation. So this, we work together very closely with computer-aided diagnosis for tuberculosis to end tuberculosis in 2030, right? So we use this software to actually screen the patients with tuberculosis. So with this software and a small box of X-ray, you can actually deliver the result. And the result from the CAT for TB is actually comparable to the bacteriological results. Easy. You don't need microbiologists, right? But again, this is not to replace microbiologists. But because Indonesia is the biggest nation, biggest archipelago nations in the world, where it consists of nearly 18,000 islands across the nation. How can you get microbiologists to every island? No, it's not possible. So with the CAT for TB, and it's already been endorsed by the Stop TB Partnership. So yeah, we work together with them, and then now the program is getting better. We not only work with foreign developer, but we also build our own, using almost the same method for AI. We published this, and I think this is the last publications. So we use the hybrid vision transformer and convolutional neural network for multi-label classifications for tuberculosis. Time is up, yep, okay. Wrap up, Eric, wrap up. So now COVID-19. So I would like to ask, to answer one of the questions from the floor. So I guess one of our friends, you mentioned about how, with the use of AI, how can I determine whether this will benefit my patients or not, right? So with this software, so this software is actually developed after we developed CAT for TB, but again, we incorporate not only X-ray, but we incorporate physical examinations data, laboratory data, medical imaging, and history taking or anamnesis, right? So what happened is, if we actually incorporate all the indices or parameters, we can actually predict. Let's say you got one COVID patient at the ER, then you working at the emergency department, you can talk to your medical director saying that, Dokter, oh, ini ada satu pasien lagi bakal masuk ke ICU. You can predict whether these patients will get worse or better with you combining all these indices or parameters. All right, so this is how we actually propose the algorithm. Again, this is another publication, and this is the one that published in Scientific Reports by Nature. So we use derivations using data set from outside our working group to validate the algorithms. Okay, so these are the common AI software that now available in the market. Last but not least, so this is the future directions. This is what we hope, right? So multi-omics is important. That's why I'm very happy with someone who mentioned about microbiome. I'm happy with the other speaker talking about the digital data, especially electronic health records, so looking forward for that. And then this is the future direction. Yes, at the beginning, us as a human will be far more superior than AI. But again, since we have a lot of things that we should bear in our life, right? So by the time the AI will be more better. I mean, will be more better in terms of doing clinical work, no. But we need to incorporate AI to our clinical practice. So this is the implementations of AI. I will share this slide. Sorry, I need to run through it. So one is early detection. Second one, optimization therapy, especially for chronic diseases like COPD. The third one for remote monitoring and telemedicine. We're now developing one of the telemedicine solutions as well, and also for predictive analysis using multi-omics. So this is the challenges and opportunities. That's what discussed in our national working group for AI. So infrastructure, capacity building, regulatory framework. So now this is my work now, doing the regulatory work for AI. So the regulations is actually now constant, but regulation will grow as AI also grows, right? Few more slides. So now I'm very happy to actually share this for the very first time as part of the Internal Medicine Society. Now we actually incorporate one chapter for AI to our own textbook, right? So this is the textbook of internal medicine. Ilmu penyakit dalam is internal medicine. So one of the chapter is about AI. So we're hoping our future generations will know about AI. And this is the decree which I just mentioned to everyone. So now we have working group or committees for national AI for healthcare. Again, I would like to end this lecture with saying that AI will never replace doctor, but doctor who didn't use digital AI, digital health, digital technologies and AI will be replaced by someone who used it. All right, thank you very much.
Thank you, Dr. Tanda. What a whirlwind tour.
Thanks.
All right, so I think we've spent most of the day hearing about the challenges, the possibilities, but I think our next talk will kind of bring it back to the individual, give you all a bit of hope and a bit of inspiration. So the next speaker that I'm going to invite is Salma Diaz Saraswati. So she's the CEO and co-founder of Tenang AI, and I'm sure she'll tell you more about it better than I can. She's going to talk about Found and Solve, how everyone can create change. So hopefully this will leave you on an inspiring note, that each of you can make an individual impact, and hopefully we'll see some of you grow, build and grow companies. I'll just put in a little note that Salma was also one of the participants of our recent Health Tech Accelerator. So in the second half of the year, apart from our hackathon, we also run an accelerator, and Salma was one of our proud participants. So please welcome Salma.
Check. Good afternoon, everyone. Thank you so much. I'm very honored to be here. Thank you for the NUS Data for inviting us as well here. And I think because this is a few last sessions of this summit, I would mostly talk about the experience and just a casual talk on how all of us here can actually create a change in our daily life. So before getting into what I built and also how this can help you as well to grow, I would ask a simple question. The first is, have you ever felt like you're hungry, but you basically don't know what to eat? I think everyone experienced that once in their life. And what did you do? Usually the options are, do you cook? If you cook, then you usually just go to the kitchen and then just cook something out of the kitchen. Or second is, do you just order food online? Because it's very convenient nowadays to just buy foods online because of the Grab food and Shopee food and everything. Or the third is, do you just like drink water and pretend you don't feel like you're hungry because you just like lazy enough to do stuff? This is also an option. So from this basic framework, you see that congratulations, you actually have found a problems and try to solve it. This is the basic framework that all of us are actually able to incorporate in our daily life to find a better solution to improve our quality of care. So I'm going to introduce a bit of what I built. I'm Salma. I've been a psychologist for the last almost 6 years now in Indonesia, and we're building something that solving the basic foundation, the basic problem, which is the mental health. So meet Tenang AI. In English, it means calm, peaceful. And the reason why we built this is, the first one, it comes from my basic experience as a psychologist. So when I was in like 2021, after COVID, the mental health actually spikes up. And mostly the young generation, the millennials, Gen Z, actually getting to my counseling system, not because they experience A severe cases, but most of them actually coming because they experience a daily stress. So for example, they experience broken heart, they experience overthinking, they experience something that we usually think, why do they have to even come to a psychologist because of such simple problem? For us, we might think that's a simple problem, but for them, after COVID, they tend to come to a psychologist because they're more aware of their mental health. They're willing to seek help even before things get worse. But the fact in Indonesia, we only have less than 3,000 psychologists for the whole populations. So yes, I think everyone here already mentioned that the shortage of clinicians, including the psychologists in Indonesia, are very, very low. That is why we need more than a human resources or psychologists to actually support the solution. So the access is not really there. They usually come after hours at night or even at midnight, but who psychologist actually up at midnight? There's no one. But mental health happens unpredictably and they cannot wait until days or even weeks to seek for help. In Indonesia, usually it takes a day or two, even a week to actually book appointment. I think it's also similar when it comes to Singapore. So the access is not really there. The second it comes is the cost. The cost for one session in Indonesia can go up to $10 to 20, even more. So not all of us actually able to address it. And in Indonesia specifically, it would take quite a longer longer time to actually able to cover this mental health with insurance. There's not much an options there. And then the third part is always a stigma. So a mental health stigma is still there when it comes to mental health. So I think these three problems really been a burden for us. And that makes us actually create an AI co-psychologist to help them, to help the users able to get an immediate mental health support for them. So they don't have to find psychologists immediately, but they can chat with an AI that feels like they're talking to a human. So for example here, I'm giving an example in Bahasa. So for example, it says here that I'm very tired the last couple of days. Even they try to speak it in their colloquial language, even in abbreviation, there's a bit of a typo there as well. But rather than giving like general responses, the AI able to understand the problems and not just giving like a general responses, but try to assess. So this is something that me, even as a psychologist, also do an assessment and an effort to actually try to understand the problem first before giving out a solution. So we built it based on the psychological approach, which is the cognitive behavior therapy and also dialectical, and that's what makes it feels like human. So we've been building this for the last 2 years now, and it feels like even now the Gen Z and even millennials trying to get a hold of it. And we've been getting more responses and feedback if this can be used by an older generations, because the older generation tends to feel a bit more lonely as their kids actually getting out of home. And we've been also been trying to see if that solution is possible as well, because it's currently still on a chat base. And for the safety, we really know that because it's a healthcare, we need the safety to be in place. That's why we are the one and only AI mental health in Southeast Asia that's able to have the HIPAA compliance as well. So we ensure that the safety in place, we ensure that the data is not getting out of the system and be used by third party or anything. So the safety is also really there. And currently we are developing it in a voice base, because when it comes to mental health, you need to hear someone speak something, and we're currently having it in English for the voice base. And yeah, because this mental health is really a basic problems that everyone's have, we see that it's also a global problem, not only Indonesia have, but even in Singapore, Southeast Asia, I mean, every part of the world actually have this same problem of mental health, the shortage of the psychologists, the wait list, the cost. That is why the impact of this actually have gotten us quite far across Asia Pacific. And what I want to talk here is because all of us plays a role in the healthcare system, also in life, basically. We believe that we all can create a change in our ecosystem, in our daily life. This is actually meant to be a slide for hackathon, but since the audience here are more professionals, also doctor, I see that this can also become the same framework that we can do to find and solve problems. The first one is always to find a problem, of course. It's obvious that I think many of us, when we feel like there's something's wrong with the system, sometimes we think that this system could have been better, we could have done better with this thing, the patient, the people could have done or could have been treated better. I think all of us actually have felt that kind of feelings. So the first thing first is find what doesn't work, or find what's actually is the problems in your ecosystem, or better in your life. So find the problem is always the first step of finding a solution. So look around you, what actually frustrates you, what could have been better, what do you want to improve. Something's wrong with the way you work or the way you do things, so find the problems is coming first. So become personalized, or look inside as well, is something that we can do. The second is that look for possible solution and add value. So our problems is not something that is new. Our problems is not something that doesn't have a solution. So we can try to list down every possible solutions that we can have out there. For example, for my problems of my patient usually just calls me up at night because they don't have anywhere to go. I used to find a solution where I give them like my second number, I give them like an appointment on the next day, or I give them like a tips on how they can get better. But turns out those solutions is not adding value, it's not solving the problems, they still keep coming back. That's where I know that the solution needs to be upgraded. It needs to be added value to that because it's not solving the solution. That is why me and my team actually found out that we should have given like a technology value to it, because it can disrupt, it can accelerate the solutions of the problem. So not just ideas, but how can you actually make it better and solve the solution. The third is always like build a prototype. So if you are working with the ecosystem, you can try to do like a proof of concept with third-party vendor. You can try to find if there is someone that's building it and try it in a small pilot teams or small pilot ecosystem first before building it up into the whole ecosystem. So from what I know, for example, your hospitals is having like a problems in giving a 24/7 access because the human resources. So you can try to give the solutions, integrating a system in a small section of the hospital first before integrating it to the whole hospital. So I think building a prototype and also try to do it in a small pilot systems is something that we need to do initially. And then evaluate and iterate. I think that's what we do as well. We try to evaluate every step. We try to evaluate if this actually working, and this is something that we can also do. If we feel like if we don't know if this problem's going to be solved with certain situation, certain solution, meaning we have to evaluate the solutions as well. So evaluation and iteration is something that we also need. Look back into like the first core problems. Does it solve the problems? Does it create something that's valuable? So that's something that we can also do for improving the quality of life. So yeah, I mean, I personally believe that because all of us plays a role in our life, because everyone has a role also in the healthcare ecosystem, we all can be a part of the change. We all can create something to improve the healthcare system, to improve our lives. So yes, I believe we all, everyone can create a change if we want it to be. So yes, you just have to start. So this is actually usually the hardest part of finding a solution, because many times we are unsure how do we start, where do we start, do we have the budget for it, do we have the capital for it. There's always a questions for it, but the thing is, you just have to start somewhere. It doesn't have to be big, it can be small, because for us, even personally, we start with manual AI first before building the actual AI, because we want to make sure that it works first. And when we collaborate with hospitals, university, and school, we always start with small groups of people first before giving it out to larger groups. So yes, you just have to start. So for me, I think because I believe that you plays a big role in your role right now. So go find, solve, and change the world, basically. Thank you.
Thank you, Salma. Before we let her go, any questions from the floor?
Thank you for your presentation. It was amazing, very inspiring. A question about the tool that you just showed to us. I'm just wondering, what are the next steps for this? If you getting feedback from people who actually use it, and yeah, basically the future, how you see it for this. So because this is amazing, and really also like, I think it is important that it goes further and you continue with it.
Okay, thank you. So the simple things about the future that I imagine from this Nasia, we call the AI Nasia, it can be like a Siri or Alexa for mental health. So imagine you can talk to Siri or Alexa for your mental health. It can be like your daily companion. I think that's like the end game of what we are looking for. But from the short term, we're planning to kind of scale the impact into a larger organization or larger groups, because at the moment we're focusing usually at schools and also small city government in Indonesia. I think we want to try it out to hospital and also universities more, because people are needing this, and I think that this is something that can add value to the people, because when their mental health is taken care of, I think they can be easily productive and improve their quality of life. Thank you.
Hello. Thank you, Selma. Great presentation. Just was interested in the application. Initially, it was text to text, and then now I think you've said it's incorporating speech but English first. So, can you talk a bit more about like what's the interaction like? Is it English, speech to then text response, or is it speech to speech response? And then also, for an Indonesian audience, what are the challenges with, bahasa, speech to text or speech to speech? Thank you.
Thank you. Yeah, that's a very interesting question. So for the English part, is a speech to speech. So you can basically talk to the AI, but at the same time, it gives you like a script on your conversation, so you can see even the conversation. And what makes it even interesting is that it can detect your emotion on the conversations. For example, you say something like, "Yeah, I'm very sad today. I don't know what to do." So the conversation will be marked as stress or distress or even quote unquote depression. So it is something that we add and also put analytics at the end, so it can understand if their mental health is improved after talking to the AI. And then the second question, the challenge is always about talent. That's the first, because finding an AI talent in Indonesia that's able to do healthcare as well is kind of challenging. And then the second is the data set, because when it comes to the data set for mental health, it's not that many yet, and the intonation of Indonesian is very various. It's not that easily, understandable. The bahasa, there are like several bahasa, even the tone and the accent and everything. So we've been trying to work on it, but it's not there yet at this year, I think. So yeah, thank you.
Thanks for all the great questions, and thank you, Salma, so much for sharing with us.
Thank you.
Okay, so we've come to that point in the afternoon. I'd like to introduce Zach and Lowell. They are the directors of DATA, also known as the Digital Advanced Technology Accelerator at the NUS School of Medicine. And basically these two started this whole thing. The hackathon, the accelerator program, it's all the fruit of their work. I'd like to start this off with what happens when a cardiothoracic surgeon and an emergency physician walk into a bar. This is what happens. So here to tell you about the challenge and the competition, Zach and Lowell.
Thanks, Jonathan. Yeah, I think a good point of it, we do go to the bar quite often to actually share this. But I think this is how we actually kind of come up with this. I think this is our first venture overseas. I think for many of you online on stream, I think we had our hackathon last year. We had InterSystems come on board with us. We had an amazing turnout, about 1,000 different participants. Hopefully many of you at home are actually also listening in. The heart of actually what Health Hack is actually to encourage more individuals of cross-pollination, because healthcare innovation is complex. Not simply just the physician or the doctor or the clinician itself innovating, but also that of the scientists, the software developers, the people who understand the operation side, the business side of things, and how can we actually allow them to cross-pollinate and allow to build together. And that was actually at the heart of what Health Hack is. We didn't simply want a hackathon just so that you can come up with an idea and collect a prize money, but actually more of, can we actually build something to build something further on? And I think data is actually a fruit of it. I think two of our alumni here, both Salma and Nelson, they actually continually push the mission of healthcare innovation and pushing the boundaries for this. So I'm going to share a bit more about the briefing for Health Hack and important dates. This is actually a joint competition, not only within Indonesia, but also that of Singapore, Indonesia. To be fair, many of our participants are also joining from Malaysia, Thailand, and they're people, it's basically a regional competition where the finals will take place in Singapore on the 29th of March. So we're just going to do a simple opening day, important date. So today is the opening day for Indonesia. We had the Singapore one on the 8th of February. And the submissions dates is combined for both. Submission opens for the same day as today, on the 15th of February on 5 p.m. And the submission closes both the same time for Singapore as well as Indonesia on the 15th of March, 2359. And the finalists will be announced on the 22nd of March. And the finals, like I said, will be on the 29th of March, where we will actually fly finalists from the region to Singapore, as well as to compete against the participants within Singapore. So each team, we usually encourage individuals to form teams of 2 to 5. I think many of you at home, some of you may be engineers, do look for other individuals who are clinicians, other individuals who are in business or spec, to actually form together and develop a solution from all the different talks you hear today. You also have access to the talks that we had in Singapore, so you can actually, based on that, feel what is the area of the greatest need and how to build up the product that you do have. The submission that you have is actually a 5-minute pitch that you have to upload up, and we will review the different submissions and eventually shortlist the finalists itself. Yep. Okay, so the two themes for this year is value-based healthcare. So I think one big focus is actually how do we increase the focus on the volume of services provided to the value care delivered, with a strong emphasis on improving patient outcomes and reducing costs. So I think that the talks from both Singapore and Indonesia actually very focused much on innovation as well as driving value-based care for our patients.
The next one is actually the silver generation. As Singapore ages, as it faces an aging population, we similarly see that across the region. How do we actually innovate for these aging population? Because many of them are usually averse to using technology. So the judging criteria is split into few ways. So one actually is very much focused on the idea itself. So the originality, the functionality, and how valid it is actually given like 50% of the scoring marks. 30% goes to the theme, whether it's value-based healthcare or silver generation, and 20% is actually on technical scoring. Yeah, the prize money is 5,000 Singapore dollars, $3,000 for second prize, and $2,000 for third place. And it's for each team altogether. So value-based healthcare is one team altogether. The other one is silver generation. This is on top of the prizes that's actually shared by InterSystems, who's our great sponsor. They will go share a bit more later about their prize and the challenge that they do have. Yep. Yep. This is the InterSystem Iris challenge that they're going to share a bit more about later. Okay. I think we can skip this. Yeah. So actually, do you have any other things to share about? Yeah. Okay. So I think we'll move on to the InterSystems sharing of their challenge, and then I think everyone can. Yeah.
Hello, thank you everyone. I'm so excited to be here, and thank you for everyone who's here in this lovely Saturday evening, and also for everyone who's here also joining online. So I'm Marilyn Wijaya. I'm a sales engineer at InterSystem, but I'm situated in the Jakarta office. So before I introduce the Gen AI challenge, I would like to explain more about what are actually our products. And first of all, we have a long history of presence outside of APEC, but actually in the APEC itself, we've been here for more than 30 years, and we have more than 10 offices in the region. We have office in Jakarta, Indonesia, in Singapore, in Bangkok, Thailand, in Osaka and Tokyo in Japan, and we also have office in Beijing, China. And lastly, in Australia, we have office in Sydney, Darwin, Richmond, and also office in New Zealand. So we're all over the region actually. And these are some of our customers both in the APEC region and outside of the APEC region. As you can see, most of them, maybe you recognize some of them, but most of them are healthcare facilities or hospital. So I get this question a lot. What do actually InterSystems sell? What are our products? I would start from the top left, which is our EMR, or electronic medical record, or maybe in Bahasa we call it Sistem Rekam Medis Elektronik. So our EMR is what it's known as the name InterSystem Tracker. So basically it's an EMR that is implemented in hospital to store patient data, and they have like multiple modules depending on the department that is available in the hospital itself. Other than the tracker, we also have our product in the middle, which is InterSystem Health Share. Basically, it's a health information exchange. But I would like us to focus on the big blue box on the bottom, which is Iris for Health Data Platform. So the two products that I mentioned before, the tracker and Health Share, are both built on top of our Iris data platform. Other than the product that we develop in-house, we also have partners, other software development company that has also built their solution on top of Iris. For example, my colleague here before, Eugenie, mentioned that Epic EMR, the biggest EMR in the world, they built their EMR on top of our Iris data platform. And you may also recognize some other our partner solution. We have also iMedway EMR. It's also the biggest EMR in China. So what actually is Iris for Health Data Platform? That it's so powerful that it can power the world's most innovative and powerful health application. So before I jump into what is Iris, I like to bring this slide. We call this slide spaghetti architecture. So for example, in hospital, you have so many systems. We start from the basic one, you have your EMR, and then you have your LIS, which is laboratory information system. You have your radiology system. Those only store the clinical data. But outside of the clinical data, you also, of course, store data for your hospital operation. For example, you also need a call center for the booking, and you also need a queue management. So there are just multiple systems that is existing just in one hospital. And as you can see here, the connection between all these systems, it gets tangled and so complicated, and it's pretty much impossible to manage and monitor. And can you guys imagine if I add one more system to this chart? I'm gonna have to add more lines to this chart that's already is so tangled. And we see this problem, and that's where one of the use case that's quite common for us, which is for intersystem iris, which we help with the interoperability or with the integration engine. So as you can see before, we had the spaghetti, but now with intersystem iris in the middle, we act as the enterprise service bus that manages all the connection to all the system in the healthcare, both storing the clinical data and outside clinical data. And now you can see if we add one more system here, it's so easy to manage the connection. You just add one more connection into Iris. So that's what makes Iris powerful, and usually when I show people this slide, they will understand, oh, that's why the company name is InterSystem, because we're connecting multiple systems. So I mentioned about interoperability, but actually Iris, our data platform, is a lot more powerful than just an interoperability engine. So actually, interoperability is just one feature of Iris. Iris itself is also a database, but Iris database is powerful because it's a multimodal database. What it means that we can store multiple formats of data, not only relational data, but we can also store unrelational data, and the latest addition to the storage is vector data. Now we can store vector data inside Iris. And lastly, so we have the interoperability to connect data, and then we can collect the data with our database. And lastly, we have our analytics engine, so we can leverage the data that we have connect and collect here. And because we are in the healthcare industry, of course, there are so many healthcare standards and formats, and it's pretty much impossible to scale if you have to configure each of these for protocol or connection by your own. And with Iris for Health, we have all the international healthcare standards or protocol built in. For example, like HL7 and also FHIR format. So it makes it easier to communicate and to connect with, may it be medical devices or may it be any healthcare system. And this is one of the use case in Indonesia actually from Prodia. So there are our Iris customer, and Prodia, as we know, it's the largest laboratory clinic in Indonesia. So they provide laboratory services. They have more than 300 sites in Indonesia. And as you can see here on the right-hand side, you can see they have multiple data sources. May it be from just their mobile app, desktop app. They also have data from their IoT or their lab instrument. And other than that, they also collect data from their social media like X. They also have file data from their accounting in Excel format. And lastly, they also store data as a voice or video on photo. So what they do with Iris here in the middle, they connect to all these different data sources, and they collect the data inside of Iris. Other than they collect the data, they also standardize all the data in the FHIR format. And now we got a clean and standardized data in intersystem Iris. And what Prodia did with this is that they started building application with this. They started building multiple mobile apps. They also built dashboard and reports. So they can find leveraging their data, because their data is not only available, but it's also already in a standardized format. So it's very easy for you to use the data. Now, I talk a lot about Iris, but I know a lot of us are in the last few years, we talk a lot about Gen AI, especially, and I would like to shift the conversation a bit into Gen AI. So the current state of the LLM is that we have these three main limitations of Gen AI. So first of all, Gen AI, they lacks, or the LLM, they lack specialized knowledge. For example, yesterday we have this room is used to talk about specifically oncology. However, LLM, they might not be trained with with a lot of data sets regarding oncology. And secondly, LLM has no access to any private information or domain-specific information, because LLM they are only been trained on publicly available data. So when we try to ask or query some question regarding something that's they're not trained on public data, they cannot answer this. And lastly, LLM they are only trained on static data set. What this means that LLM are only been trained with data until some point in time. So when we ask, so they don't have basically real-time information. So LLM, if we ask them information, especially regarding 2025, they wouldn't have the answer for this. So all of this limitation will make LLM prone to hallucinations. They will start giving answer that actually not right, and of course we don't want that. And InterSystem, we love challenges, but we also love solving problem, and we see this problem. And because of that, in InterSystem, our Iris data platform, we have what we call vector data and vector search. Vector data is pretty, as the name suggests, so we can store vector data in our database. But what does vector search mean actually? I'll show a graph here. So vector search, in a simple term, it means that just find similar items in your data set by comparing their numerical representation or their vectors. So I have an example here with the graph. On that side, I have multiple data sources, again, from unstructured data like image, document, or audio. I store them in Iris vector data. And then I have a user on this side. This user query, they want some information from the database. So what vector search is doing here is that they can find the similar items in the database based on the query or the input from the user. And they will output the most similar or most relevant data to the user. This actually helps a lot. So instead of someone has to go through the database by themselves, it will take forever to do that. They can just reference this vector search. And actually this vector search is the one that can help us to do RAG or retrieval augmented generation. I'm pretty sure my technical audience, they have heard and know about this RAG. But basically with RAG is you're trying to fit some relevant context into the LLM. You're trying to fit some data that LLM is not trained on, so they gain more knowledge and they can help answer the user query. So with our vector search, that is built natively inside of Iris. It's pretty easy for you to leverage and use it for RAG. And we have talked about the technology. So how can we use it for healthcare? These are I'm just mentioning two simple use cases here. So first of all is to use it as a clinical decision support. So the first thing I mentioned here, like when physicians, they want to summarize the patient record, but they may also want the patient record to be summarized with the latest research paper, but it will take them a lot of time to do this manually. So with a system that has a rack-powered assistant inside of that, it's pretty fast for the physician to do this summarization with additional data that are not known to the LLM. And secondly, we have also patient engagement and education. So me, myself, as a human, we like to ask Google like about when we have some symptoms or some disease. But when we ask Google, we don't provide any data about our medical history. But with this system that is powered by inter-system vector search and also LLM, we can fit our medical record and to the LLM, so they have more context in answering our question. So these are two use cases, but actually the possibility here is limitless for you to leverage RAG. And that's why we Intersystem partnering with NUS for their Health Hack Hackathon 2025. Because we would like to see all the innovation you guys can bring into healthcare, but we also would like you guys to explore also our product, and especially our intersystem iris vector search. And as my colleague mentioned, we have best use case of Gen AI challenge here by leveraging intersystem iris vector search. We have cash prizes, but on top of that, for the first place, you will get a spot in our accelerator incubator by bypassing all the selection. This is just a bit of history about Intersystem in the hackathon world. So we've been sponsoring since around 2021. And for this year, this is the first time we are partnering in this region. And I'm super excited because, of course, I'm from this region and I'm excited for this. And we have some learning materials for you guys to revisit. And on the bottom here, we have our developer community. So our developer community, you guys can access through this link, community.intersystem.com. But for our developer community, basically it's an online collaboration forum where you can also post some technical question, and we have our moderator to answer. But we have a lot of best practice article also inside of our community. And we have also our developer community AI, where you can ask the AI any technical question, and this AI actually is powered by our own technology, which is intersystem iris vector search. And actually, this is the last slide for my presentation. You have the biggest QR code on the right side is for your quick start. When you scan the QR code, one of the link will direct you to the GitHub where you can clone the sample code that you have provided, and you can start leveraging our iris vector search. And I understand that this presentation would be a more general or high level of our product, and because of that, we have a technical workshop that will be held on the 20th February. I will be your host for that once again, so for everyone who wants to see me again, please tune into this workshop. And lastly, if you need any support technical, we have our developer community once again, and we have also our Discord server to answer all your technical questions. So I'm really looking forward for all the innovation you guys will build during this period. And happy hacking. Thank you.
Thank you so much, Marlene. Thank you. Yeah, thank you. So, thank you, everyone. I think this comes to the end of the Bali edition of Health Hack. Do take note of the QR codes, and basically, I think as of today, as in now, actually submissions is open for Health Hack in Bali. Hoping for you all to submit before 15th of March, and then hope to see you all on the 29th of March for the finals itself. Thank you all for coming. Please enjoy the rest of your time in Bali, and yeah, see you all in Singapore. Okay, thank you.